नहीं नहीं, उनका तो आना चाहिए। हाँ, हेलो हेलो, उनका ऑडियो नहीं आ रहा, मत खोलो ना अभी।
Hello, sir.
सर टेल मी।
Yeah, I can hear you, sir.
यस यस, आई कैन हियर यू सर। सो कैन यू स्पीक अगेन?
Yeah, sir. Are you able to hear me?
यस, परफेक्टली ओके।
Perfect. Yeah, sir. Perfect.
सो आई प्ले वन 1 minute 15-second video. Can you see?
Yeah, yeah. Right.
Yeah, this level is fine.
Yeah, sir. Yeah, sir. Audio and video both are perfect. Fine.
So Kishore,
Yeah, sir.
can we continue with this login right now, or we need to log out?
Sorry, sir.
Can we continue the session right now till 6 p.m., or we need to log out and then we will log in at 6
Yeah,
a.m.?
actually, that's you're comfortable, sir. We will be online till starting now. So
So
now
so let
to
it
till the
so let it be. Kishore, let it be on. We will be signed in
okay,
from now till the session ends.
okay, fine.
Okay.
Okay, thank you.
नहीं मैं वैसे पूछ रहा हूँ।
Hello, Kishore, are you there?
Yes, sir.
Okay. So can you see? Yeah. Can you see the screen right now?
Yes, sir. Yes, sir. I'm able to
Is
see
it
your screen.
perfectly fine or something has been cut?
No, no, it's perfect. All right.
Everything
No
is
issue.
visible.
Yes, sir. Visible. It's visible. It's visible.
Okay.
Okay.
Thank you.
Okay. Thank you.
Kishore sir, hello.
Yeah, sir, Prashant.
Okay, I joined. Okay, I'm ready.
Yeah, okay, sure.
ಕಿಶೋರ್ ನೀವಿದ್ದೀರಾ ಅಲ್ಲಿ? ಕಿಶೋರ್?
Yeah, sir. Prakash here.
ಪ್ರಕಾಶ್, ಕಿಶೋರ್ ಅಲ್ಲಿ?
ಇದ್ದಾರೆ ಸರ್.
ಹಾ ಸರ್.
ಏನ್ ಮಾಡ್ತಿದ್ದಾರೆ ಅವರಲ್ಲಿ ಜೈಪುರಲ್ಲಿ?
ಜೈಪುರಲ್ಲಿ ಅವ್ರು ಕನೆಕ್ಟ್ ಆಗಿದ್ದಾರೆ ಅಷ್ಟೇ, ಅವ್ರು ಏನೋ ಮಾಡ್ಕೊಂತಾರೆ. ಎಲ್ಲ ಟೆಸ್ಟ್ ಮಾಡಿದ್ರು, ಓಕೆ.
ಇದೇನಿದು ಪಿ ಮಾಡ್ತಿದ್ದಾರೆ? ಪಿಕ್ಚರ್ ಏನಿದು?
ಅವ್ರು ಶೇರ್ ಮಾಡ್ಕೊಂಡಿರೋದು, ಆತರ ಶೇರ್ ಮಾಡ್ತಿರೋದು ಅವರು.
ಹೆಂಗ್ ಶೇರ್ ಮಾಡ್ತಾರೆ? ಪಿಕ್ಚರ್ ಮಾಡ್ತಿದ್ರ ಶೇರ್?
ಸ್ಪಾಟ್ಲೈಟ್ ಒಂದು ನಿಮಿಷ ಸ್ಪಾಟ್ಲೈಟ್ ಮಾಡ್ತಾ ಇದೀನಿ, ಎಲ್ಲ ಮೇಲೆ ಬರುತ್ತೆ. ಹಾ
ಅಲ್ಲ ಅದೇ ಪ್ಲೇ చేయాలి రెడీ కాడాను పంకజ్ రఘు లాగౌట్ అయిపోయింది
మాట్లాడవాలతో.
Hello Pankaj sir. Pankaj sir, are you able to hear me?
Jaipur team.
बोलिए, सुन रहा हूँ.
Jaipur team, are you there?
Yes, tell me.
Yeah, so can you change to video mode, camera?
Change the video mode. वीडियो आपको नहीं मिल रहा है?
Camera, can you change to camera?
Okay.
Also, we are getting very low audio from your side.
What?
Change to camera, only camera.
नहीं, मैं चेंज कर दिया सोर्स.
No, your audio is very low.
मैं अभी कंसोल से ही बात कर रहा हूँ. आपको ऑडियो लो मिल रही है. एक मिनट, अभी क्लियर है?
Yeah, अभी क्लियर है. Can you change to camera?
चेंज किया मैंने. कैमरा चाहिए आपको? क्या चाहिए?
कैमरा वीडियो.
देखिए.
हाँ ठीक है.
ठीक है.
You can keep it like this. Raghu sir. From Cath Lab, can you check anyone audio?
Center.
No, from Cath Lab, can you check audio with mic?
चेक है, ऑलरेडी चेक कर लिया सर. डॉक्टर आएंगे, माइक लगाऊंगा तो कोई दिक्कत नहीं है. चेक किया हुआ सर.
ठीक है.
डन है.
ठीक.
ओके, इसको स्टैंड बाय रहने देते हैं सर, सब कुछ
ठीक.
डन सर.
Hello. Can somebody who's a technician from Jaipur speak to me, please? I'm talking from the back end. Hello.
Yes.
Can a technician from Jaipur talk to me, please?
Yes,
I'm
yes.
talking from the back end. Hello.
Yeah, विकास here.
Because see, आपका audio level बहुत down है, बहुत low है.
नहीं, मैं अभी कंसोल से बात कर रहा हूँ. आपको भी क्लियर मिल रहा होगा.
अच्छा, मेरा रिक्वेस्ट क्या है, आप जरा आपकी मिक्सर में जो लेवल है ना उसको बढ़ा दीजिए, मैक्सिमम कर दीजिए.
अभी क्लियर है आपको?
अभी क्लियर है, ऑडियो क्लियर है, मगर ऑडियो लेवल बहुत लो है. क्लियर है ऑडियो आपका? सुन रहा है? तो उसको बढ़ाना है, आप बस थोड़ा ज्यादा करना है, वॉल्यूम ज्यादा करना है.
करके रखूंगा लाइव पीरियड में.
हाँ ठीक है, मैं बोल चुका हूँ, तो आप देख लीजिए क्या करना
ओके,
है।
नहीं नहीं, अंडरस्टैंड। आप मतलब आप ये करें कि जब लाइव चलेगी तो उसमें बढ़ा के रखूंगा, यही ना?
हाँ हाँ ठीक है, नहीं अभी भी कर सकते हैं, क्योंकि अभी भी करके म्यूट कर दीजिए आपका, कोई किसी को नहीं सुनना है तो म्यूट कर दीजिए बस।
अभी चेक करिए, लेवल ठीक है आपको?
नहीं लेवल ऐसा वैसे की वैसा ही है,
नहीं नहीं, अभी
अभी भी ऐसा ही है।
ऐसे कैसे हो सकता है? एक वो माइक लगा लो दोनों जाकर, मेन माइक तुम लगा लो।
किशोर, किशोर,
क्या सर?
ಕಿಶೋರ್ ಬಿಸಿ ಇದ್ದಾರಾ?
ಹಾ ಸರ್, ಅವ್ರ ಜೊತೆ ಮಾತಾಡ್ತವ್ರೆ.
ಈಗ ನಾನು ಒಂದು ಫೇಸ್ಬುಕ್ ಲಾಗಿನ್ ಐಡಿ ಕೊಡ್ತೀನಿ, ಅದರಲ್ಲಿ ಇದನ್ನ ಫೇಸ್ಬುಕ್ ಲೈವ್ ಮಾಡ್ಬಿಡಿ.
ಓಕೆ ಸರ್.
ಆಗುತ್ತಾ ನೀವು ಮಾಡಕ್ಕೆ?
ಹಾ ಸರ್, ಅಣ್ಣ ಇದಾರಲ್ಲ, ಏನಾದ್ರು ಡೌಟ್ ಇದ್ರೆ ಕೇಳ್ತೀನಿ. ಓಕೆ.
ಹಲೋ,
ಹಾ ಸರ್.
Hello, check, 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 check. Hello, hello, check,
हाँ सर, अभी थोड़ा
check,
अच्छा है.
check, check,
हाँ.
check. Hello, hello,
Hello.
check, check. Hello, hello, check,
या सर, अभी थोड़ा ठीक है आपका वॉइस.
check, check. 1, 2, 3, 4.
हाँ हाँ, अभी ठीक है सर.
5 minutes.
दो माइक्रोवेंचर
अभी करा करा
हीमोग्लोबिन पहले डायरेक्टर दे दो या फिर शीट से दे दो, डायरेक्टर दे दो पहले, नहीं निकालो इधर, अभी अपने पास में टाइम नहीं निकालने का। एक स्लाइड्स कहाँ पे दिखेंगी हमारे को? स्लाइड दिखेंगी? लाओ दिखाओ। ये हटा दो, शार्प सड़क वे कर दो, ये बाहर ले लो, दाई भर के ले लो। हीमोग्लोबिन कितना बताया आपने मेरे को? हीमोग्लोबिन सर्वर, ठीक है। अच्छा दिखाओ आरओ में। हाँ नेक्स्ट। ठीक है, ओके, कम आउट। बाहर तो दो।
हाँ दे दिया मैंने, दे दिया। इसको डिस्कार्ड करके लोड करके रखो। बस अब जो है तो हो गया है।
रशीद दो विद लेटर डालो उसमें।
बाद में मतलब जो रिक्वायरमेंट होगी
नहीं शीट डालनी है, टीपे डालना भी।
कंप्लीट अनलॉक।
Hello, check. Yeah.
या इस विषय डालो 6.3। बॉडी वेट कम है तो 6000 हैपनिंग। टीपी रेडी दो पर सब क्लीन कर दो यहाँ से। अच्छा हेपरिन दो यार। हेपरिन वैसे है कितना? 10,000 ना, मैं 7,000 हुआ। 7,000 बॉडी वेट 44। ये लो एक फ्लश इसी में दे दो एक बार दोबारा मेरे को। टीपीआई लीड दो। चलो डन। गिव मी द टीपीआई। हाथ को नीचे रखिए सब, हाथ को नीचे रखिए। हाथ ये हाथ को नहीं ऐसा नहीं करना, ऐसा नहीं करना। अरे यार ये तो बीटा डालना पड़ेगा। तो क्लीन विद बीटाडीन। ये इनका हाथ नीचे को रखा है या तो पीछे रखते। बीटाडीन जल्दी डालो जल्दी जस्ट डू इट फास्ट। और ये ना ये सुनो, ये गॉज पीसेस जो गंदे वाले हैं ना, फट से निकाल के पीछे करो। बीटाडीन से क्लीन करो। टीपीआई लीड दो फटाफट। गाइड करते रेडी। हाँ सो डाल दो, क्लीन भी करना इसको। बस आपने हाथ लगा इसलिए हाथ नहीं लगाना बिल्कुल भी। ड्राई गॉज पीस दे दो। एंटीबायोटिक लगा हुआ है इनको। दिखाओ दिखाओ, शो मी द
inflate sir.
फ्लोर। एक तो इसको पहले थोड़ा सा कर लेते हैं, एन वाई है ना।
हाँ
TPI check, partially deflate, and TPI check, watch pieces ले लो, TPI को check कर दो, फ्लूइड चल रहा है, चेक लो, फ्लूइड को नॉर्मल सेट से चालू करो, देवेंद्र, हाँ चलो, या थ्रेशोल्ड बताओ, अच्छा फ्लूइड चला, नॉर्मल लाइन से फ्लूइड चलाओ, और एक नॉरेड इन्फ्यूजन बना के रखो, और ADR एट्रोपिन स्टैंड बाय, गाइड कितने से दो, गाइडिंग 6 FGR, नहीं ये अपने को वो चीज नहीं सारा लाइव नहीं है, अपने को आईवस तक अपने को करके रखना है, सबसे बात तो मेरी, अपने को क्रॉस करना है, आईवस करना है, निकाल लेना है, रोटा वायर कर देना है, और अपने को बर को वहां रखना है, देन इट बिकम लाइव, क्योंकि वो फिनिश नहीं फिर आईवस इसको ये लो, ये इसमें एक्सटेंशन लाइन लगा दो, लाइव होने तक अपने को रोटा बल के पास में है, क्योंकि ये 45 मिनट्स का है अपने ट्रांसमिशन, RC अपन नेक्स्ट 10 मिनट्स में करेंगे, 6:05 पे लाइव होंगे, तो 6:20-25 तक करना है, तब जा करके अपने को 30 मिनट्स मिलेगा LED के लिए, या 20 मिनट्स मिलेगा, तो LED बाइफरकेशन भी है। लेकिन सर ने मेरे को बोला कि ये ना LED में ना डायगोनल में जो स्टंट है वो ऑस्टिन तक नहीं करेंगे, लेकिन there is no landing zone as such.
Asking for some secondary checks.
Yeah.
Let me add one more person on the call.
Diagonal मतलब proximal करेंगे, ऑस्टिन पे नहीं आएंगे, will not
Some other ID?
नहीं, but there is no landing zone, पूरा डिजीज है।
Yeah, some other ID?
रन करके ये देखो, रन करो, हाँ पूरी या
Prakash, ask Kishore to take the call.
या वो दिखाओ नीचे दिखाओ, वहाँ बाहर जा रहा है, ठीक है 300 लिए अब, ठीक है 7,000 एप्रिन गिवन ना, आनंद एक रन थ्रू वार दे दो, और प्रेशर्स दिखा दो यहाँ पे, प्रेशर्स ठीक है, प्रेशर्स ओके, 160, yeah floor images, या चलो एक बार पहले एक वैसे बस फ्लोर वाला सीने लेते हैं एक बार, है ना, सीने में कैल्शियम थोड़ा सा, हाँ बस टीपे वाला कर दो, बस एक ड्राई सीने, हाँ बस एक फ्लूइड नॉर्मल सेट से चालू कर दो, थोड़ा सा पीछे करो आराम से, चलो आप, हाँ ये ठीक है, ड्राई सीने लेते हैं, या 300 पीटी से 600 हो जाएगी, 600 हो जाएगी। हाँ 600 कर दो, कोई दिक्कत नहीं।
दिखेगा नहीं आनंद जी, वहाँ पे स्लाइड आएगी आनंद जी। और इधर
इसको तो एनलार्ज, उसको एनलार्ज करके करते हैं ना ये।
सबको चाहिए होगा ना, बाद में निकालना पड़ेगा।
टॉकर लगा दो। ये मेरे को लगता है कि जिस इन द पीडी, आई थिंक इट्स इन द पीडी और पीएल। नो नो, एक बार स्मॉल चेक देखो।
Same view all 39.
मतलब इट्स माय गॉड, that catheter is coming out. You see me? एक बार देखो यहाँ पे, व्हाट इज द इशू भाई? ओह ये मैं कर रहा हूँ, चलने दे यहाँ पे।
I was crossed or no?
स्मॉल चेक देखो, पीडीए में एक बार देखो। या तो पीडीए में कर ले, कीप इन द सब पीडीए एज अ लूप। तो पीडीए में आगे आगे कर देते हैं।
ठीक है सर।
So in the PDA, we're deep into the PDA. So we can take our student first. I was there.
हाँ अच्छा, गुड। हाँ वो ठीक है। Show the last. This is the only picture we have so far, right?
Yes, because we haven't taken any. This is a fluoroscopic run.
Very good.
And we have angiographic views just to preserve the contrast media because EGFR is less than 30.
हाँ जी बिल्कुल सही काम हो रहा है। बस आधा पौन घंटे में give more sedation. He wants to sleep. Yeah. He wants to sleep.
Heparin 7,000. Body weight is 44. Heparin 7,000.
And sometime later, just check the ACT.
Yeah, there is tight.
Good. That's it. Okay. Just Sine, done. Good. Good.
Stucking in the lesion.
That's okay. That means very tight. Good.
Very tight. Yeah.
Okay.
Take the IVUS.
But still, we have the proximal portion. We can record.
Yeah.
Yes.
Connect the IVUS. Yeah.
No, the very real normal man. Here, there's nothing there. We don't have to show anything there. Good. Yeah. Nothing. Good. Yeah.
So we can direct with the 2 millimeter balloon and make the space for this. And
No. Done.
Take it out.
Yeah. Definitely. No.
So take out.
Yep. Yet.
So it's because of tight lesion, we're going straight away with the rota. Macro catheter, so we can exchange. Another catheter. Yeah. You can go side by side.
Mohan sir, good evening. Good evening, Dr. Das. Good evening.
Yeah, give me the introduction.
Everybody are mute.
Good evening, everyone. Dr. Mohanan, Dr. Tagi, Dr. Arneja, Dr. Sharat.
Dr. Sharath and Dr. Jaspal.
Yeah, good evening, good evening.
Good evening, sir. Good evening, sir.
Hi, Jaspal. Good evening.
Hi, good evening, sir.
Your meeting was fantastic.
Thank you so much.
Great
Sir.
job.
Because all of us were participated. I think Dr. Samin Sharma was also there.
Right.
So he had a very nice live case from New York.
Let's try to go into PDA. The PDA will be a bigger area.
PDA?
For washout, yeah. Good. Good. But just leave it. You don't need further. Take the other wire out.
Is talker out?
Okay, we'll be getting live in next 5 minutes. Actually, now.
It is already live.
We are already live. That's good.
Yes, already live.
Live. Dr. Samin Sharma.
You're muted.
MK
Your audio is muted.
Yeah. Minal.
Hi, hi. Dr. Kahali. Good evening.
Good evening. Dr. Kale, good evening. And of course, I hear a lot of our panelists and moderators for this exciting, today the second day?
Today's day.
Day one.
Yeah.
The day one, right?
Yeah, Friday is the day one. Yeah.
Good evening, Dr. Das. Good evening, Dr. Kahali.
Good evening. Good evening.
Good evening, everyone.
Yeah, good evening, everybody, and I welcome you all to our national NIC CSI monthly meetings. And I greet all of you, including our foreign faculty and especially Dr. Shamin Sharma, who is on live and will be showing it. And just to tell that this is our again mute.
Ali, you are muted.
Yeah, no, it's okay. Yeah, it got muted from the central end. So I greet all of you, and I hope that it will be a very successful webinar like all the other ones. This is the 5th one in our series, and Dr. Shamin Sharma will first show a case. And I greet all of you. We know that we are again on the second phase of the corona pandemic, and yesterday 36,000 patients have been, only in Mumbai they have been affected, and total in India 59,000. So we are going to face another crisis, but we have come over all the crises. We had successful webinars from Dr. Mrinal Kanti Das, from Dr. Mohanan, from CSI and CSI NIC. And I greet all the foreign faculties. And I think that during the next few months also, whatever comes will be sailing smoothly. And I just asked my friend, Dr. from Kerala, who is our vice president and of cardiological society, the program with Dr. Shamin Sharma. So Dr. Mohanan, please.
Thank you, Dr. Diman. It's a privilege to be part of this exciting days program, and have a special welcome to the 6 international faculties and all of you who has logged in. When it comes to revascularization of a high-risk patient, there seems to be a risk treatment paradox. See, these are the guy who merits it maximum, but then unfortunately they're not either not advised properly, or many a time they are told that this is not possible to do. But the refinement in the patient selection criteria, and of course, advances in the interventional cardiology and the collaboration with the heart team has made it a different cup of situation right now. And I'm sure now these continuing effort by the able leadership of Diman in the CSI and NIC, we will make this SHIP program a high risk, high rewarding program. Thank you and all the very best for this program. Next 4 hours of intense activity.
Thank you, Dr. Mohanan, for your kind words, and I greet all of you. So I would request Dr. Shamin Sharma and his team to start it. But before that, let me talk about today's moderators and chairpersons. Dr. Sharad Chandra, I can see you. Dr. Jabir Abdullah Kutti, Dr. Nitish Naik, Dr. Ejilan, Dr. Shomit Dani, Dr. Dilip Kumar, Dr. Devobroto Rai. He is our General Secretary of Cardiological Society of India. Dr. Minal Kanti Das, Dr. Anil Misro, he is from BM Birla, our center. Dr. Jaspal Arneja, and Dr. J.S. Makkar. So I hope all of you have joined, and please support and ask your questions if anything to be asked during this demonstration of this live case. And I would request Dr. Sharma. I think none of us need the introduction of Dr. Shamin Sharma. He is the Director of Cardiology and Intervention in Mount Sinai Hospital. And we regularly meet every fortnightly. I think just a month back, we were together in a Mount Sinai meeting. But this time, he will be showing from his own center in Jaipur. So that's a great privilege and pleasure for all of us. And Dr. Bahal, greetings to Dr. Bahal also, I can see. So Dr. Bahal, please you interact with us. So Dr. Shamin Sharma is with us and he will be live. So Dr. Shamin Sharma, can I request you to start your patient, talk about the patient and if you proceed. Thank you. Dr. Sharma, can you listen to me? এটা শোনা যাচ্ছে না কিছু কেন অডিও না শোনা
Dr. Sharma's things are muted actually. Pankaj Kumar.
I think Raghu, you should look into the matter.
Yeah, sir, they have to unmute. We have already told them many times. So Jaipur, please unmute your audio. Jaipur, please unmute your audio.
Dr. Sharma, if you kindly unmute your audio for the time being.
More sedation to be sleeping. Okay. Now, Dr. Diman, can you hear us now?
Yeah, clearly, Dr. Shamin, clearly.
Very good. Beautiful. And just want to start now thank you for giving opportunity to showcase in this the CHIP PCI conclave of the CSI NIC webinar, and we'll try to do live cases. And I have heard most of our friends as international faculty, the guest faculty there and panelists will need a lot of opinion. And the task was given to me today is to show a case of complex coronary with a calcification and using the plaque modification strategy based on the calcium. And as you said earlier, Sharma, this is the Sharma square actually from today. From my case, K. Sharma and Sanjeev Sharma on my left side, Director of Interventional Cardiology. And then we have a lot of our cath lab staff, including my associate and here. So with that note, we start this case. We have the slide quickly show. Prashant. Prashant is my right-hand person here when I come for 2 days. He assists me in all the cases. He actually will be coming in July for 1 year of intense training in interventional cardiology at Mount Sinai. And this case actually was done earlier this morning. And maybe they can just show the 80-year-old male with the history of hypertension, not much in terms of prior history, except there's just weight loss and tobacco chewing, and has pre-syncopal episode 10 days back. Next. And basically, the workup showed some dynamic SCT wave changes, and echo showed LV dysfunction. The little hypokinesis initially was lower, but then subsequent echo came about 60%. Creatinine is 1.6, and has basically carotid Doppler also, which was okay. So we did the angiogram earlier. If we can quickly show the angiogram, you can see the right coronary, or your left. Yeah, left. Start with the left now. Yeah. Clearly, I say that to assess the calcium, one is the imaging. You can do OCT IVUS, but very simple. It just go with the fluoro. So before giving the dye, don't go next. Leave it there. Yeah. Before giving the dye, look at the silhouette of the vessel. If you see tram track, play again. And you see before the dye, this patient has a severe calcium in the LED and diagonal system, as you can see there. In the diagonal.
Yeah, it's very much evident, Dr. Sharma. Yeah,
very much good.
Yeah,
And
both
next,
are very much calcified, highly calcified.
Yep. Right. And the circumflex is spared. Left vein is all right. Next. And here, this is the right. Very, again, before severe LC, although it's a short lesion, but 90+% severe calcific mid RCA, although lesion goes to the proximal. This is clear to everybody, to all our viewers as well as to the panelists?
Yeah, all are clearly visible, Samin.
Good,
Beautifully
good.
shown.
So, yeah, and just to say that what everybody had published, including ourselves, that this kind of case, if you cannot, you should, if somebody wants to do IVUS, I say, okay, you do a theoretical interest, because this case does not need IVUS at 0 time. You may need IVUS during your process, during the procedure, you want to decide your stent and expansions and so, but not here. But it's still just to prove that point. Next, we say, let's do the IVUS. Next.
What is the procedure?
Yeah. And here, this is the guide. We put a run through wire, and this is happening to the IVUS catheter, not making the turn. So that by definition makes it a severe calcification. But we knew that this was severe calcium, but this is just for people to educate, because I always get into this. So we need to see the IVUS to see calcium. No. Once you have this degree of calcium, sometimes IVUS may be more harmful, may lift the plaque. A stable patient may become unstable. So with that note, so we change it. We put the rota wire side by side, and we are ready with the rota 1.75 bar. The rota floppy wire has been advanced, and they can see this. No.
Check it first.
Yeah. So we are going to check the speed outside by holding. I know this camera may not just try to see the speed now. Usually about 155 outside. Good. And we still have the old rota classical system. Don't have the rota, the pro, which will be available soon, and push and pull. The right coronary, in this case, that's why we're putting a pacemaker. Although if you want to avoid the pacemaker, you can do it by giving atropine and aminophylline. But here we said, let's just keep the pacemaker. That to me is less of an issue. Now guide, you have to keep the guide 1 second. Now they're making the new wire, rota direct. It's a new wire with rota coming, a little more floppier. Let's advance a little bit in. Yeah, go in burr, but let the burr come out of the guide. Always try to, if it can come out, it's good. If not, then you have to do Dana guide. Good, that's fine, because there's no calcium disease there. So once it is done, then you do, which we have taught multiple times, advancer knob back and forth, and at the Y connector, and then just tap on the Dynaglide. So keep the Dynaglide on. Yeah, just tap on the Dynaglide. If you have to jump, good, did not jump, good. Once it is ready, the Sanjeev will be doing the rotational atherectomy, holding the guide catheter with the left hand, and starting, this is a 1.75 bar. Go and touch back. Keep it 150, don't change anything. No, don't change the speed. Yeah. And keep seeing the blood pressure. Systolic blood pressure should not go down to less than 100. We actually have a lot of our cath lab. Yeah, wait, 20 seconds. So 20 seconds. So going through all the steps for everybody to, the cases I do here, 6 to 8 cases on my one day, they all more than 50% are with the rotational atherectomy. Go, start. Yeah. The other device, the orbital, Of course, the IVL is already here. Orbitals also will come shortly. Now, clearly that this, okay, yeah, 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 good. So it went in, it jumped. At that time, clearly that you can see the pacemaker, the hemodynamics showing below in the screen. But since it's still okay, if you start getting bradycardia, you can always increase the pacemaker speed or give atropine. Issue is many times by giving up the pacemaker, speed, pressure goes down because you lose the atrial kick. But here, so far, so good. The polish there, a little further down. Also, yeah, good. This area polish because we are going to stand that segment. Good. Okay.
Dr. Sharma, may I have one question?
Yes. Yes. Of course, a question allowed any time.
Did you have anything in mind? Did you have anything in mind for not using the intravascular lithotripsy and you chose the rotablation? Any extra point to take up actually?
That's a very good point. So question is, can this kind of a lesion be done with the with the IVL compared to the rotablation? Answer to that is yes. You can do this, put a rota with the run through side by side. Yeah, so question only will remain the cost by this. We are trying to figure out, because I have done at least 3 papers in various review articles, JAK interventions and so, how to treat the calcific lesion. I still need to include the IVL in the equation because recently approved in USA. The question will always come that at what point you use this expensive device. So same way in America, the rotablation is about $1,600. IVL, one catheter, you don't need the oil. One catheter is basically $4,000. So if you need to use one, more than one, the cost will go further. So same thing here is 3 lakh rupees.
Yeah, IVL, yeah, 3 lakhs.
That's fine. Yeah. So now we had advanced the side by side. The wire. Now question comes that do you take the rotawire out or you leave the rotawire? So in order to get IVL catheter, you need to do pre-dilate, and you needed to, which could be done in my opinion with a 2O balloon, and then use the IVL. Yes, nothing wrong in that. Only question will be that how much the cost-wise it will be, or is there advantage of one technique versus other? Go.
Now we have taken a Wolverine, the latest cutting balloon, which has got an excellent deliverability and trackability, and can reach to the distal part of the vessel very easily.
So, and the question will be also, knowing that the rotablation require the rotablation definitely require little technical issues, but IVL can be done much easier. So that will be another use of the IVL go up. So this is the Wolverine, which can go easily to 16, 18 atmosphere. That's okay. Yeah. So key is that even if your lesion, the Wolverine doesn't cross, as long as you are done in the proximal segment, you cut it. Oh, hands down.
Yeah, go again.
Yeah, go again. You're still leaving a rota. So the 3.0 had the 3 blades, 3.5. Now basically the 4 blades now. 4 plus, yeah. So it's still, actually there is still a
waste.
So pull back a little bit.
Yeah.
And we do it once again.
Yeah, go again.
Yeah, go up and again. So clearly you can change the rota, cutting balloon direction once or twice to come back in the guide and then go up to 12 to 14, but go negative. I would come back in the guide. Hopefully then the blade goes into the different direction. Go again.
Yeah. Now it's going easy.
Yeah, no, but we have to take care of the lesion.
Yeah.
Yeah, let me just see. The first time I'm giving little dye. So far we have done nothing with the entire case with the dye. Good. Yeah. That's good. Go up.
So CKD, we are preserving the dye.
Yeah. Yeah. Negative.
Same.
Okay. We have to pull back a little bit. Yeah, here. Go up again.
Center.
Good. I think it's done it. Yeah, 12, 14. Yeah.
There is extensive calcium, the eccentric opening of the balloon.
Yeah.
So, Dr. Sharma, you go to high pressures with a cutting balloon? What
the Wolverine, you can go 16 atmosphere without any problem. Let's get a stent. What do you want?
And
3.5
cutting balloon routinely
0.5, not 38.
The 38 will cover the lesion. Measured.
38?
Yeah.
Okay, 38, good. So yeah, the question is 3.5. Yeah. The question that do you combine? I would say usually I would have gone in this particular case just with the high pressure. But today we just wanted to show a combination of alternate combination, which is still cheaper, I would say financially, that using a one rota bar. Many people will do the IVL after the rota with the rota tripsy concept, but we are using the rota cutting balloon. But yes, high pressure balloon could have been fine. Not all cases will use in the short lesion here. I basically would have just gone back with the high pressure 3.5. Here, there's a mild disease pre and post. So we are just covering with this 3.538 Promus Elite. Yeah. And then we'll dilate inside with the, actually will be a, give us a 3.5 balloon. Yeah. Yeah, that's fine. That's after delivering. Yeah. So same in complex case, the pointage of the chip, complexity, you have your rotawire, deliver your device, then only you take, good. We are taking the rotawire out now. Now, even if somebody forgot to that, you forgot to bring the wire out and you have inflated the stent, that's okay. We actually have published that many times before the guideliner that you may need to jail the wire entire length to deliver the stent distally. And so pull back, at least 6 millimeter pull back, good.
You can check it here.
Guide a little bit back out.
Yeah.
Good.
I think that's okay. You can go.
Okay. Go up. Now here you want to do, I was ready, right? Is I was ready?
Yeah.
10, 12. 14.
15.
Yeah, negative. So we usually go 2 times 16 atmosphere, go up again. Now definitely in the vein graft, try to go lower pressure. Yeah, negative.
Save.
Yeah, you take a little time to deflate.
Yeah, it's a long balloon. Moving forward.
So that will be the biggest question will come in my mind that, again, it's all the comfort level. Some people may be concerned that, this rotablation, we do slow flow, this and that, but that what will happen with the various complications with the rota and so, I mean, correctly done, the complication of the rota or whether there is clearly no comparison, even registry wise or so. We have a published comparison of the rota and orbital. Definitely nothing from this point of view. Just do the IVAS here. Yeah, so we are going to do IVAS just to see our lumen, minimum lumen, at least we are expecting 6.5 and above. If any area not expanded, we have the 3.5 or 4 balloon and go and optimize it, and then we get ready with the left. Left VL guide, we have what?
Yeah, we have VL3.
Okay.
And there's so much of calcium, it's a routine practice to do a post-dilatation.
Yeah.
But
yeah, so question comes is that should you do routine post-dilatation, particularly if you're using the imaging, then it's, I think you can avoid it. One, then you had done already the cutting balloon already. Okay, let's start. Can bring the IVAS on the screen, please?
Yeah. Yeah.
And we get the IVAS expert, they'll comment on it. There's just a lot of calcium, but good lumen.
Yes, looks like deep calcium, but lumen is good. We have a vessel size, which is 3.5 millimeter here. Eccentric plaque, looks like fibrotic. Eccentric fibrotic, 6 to 12 position. We have a stent here. Distal edge is safe, which is well opposed and well dilated. Well opposed, well dilated. We can see eccentric plaque from 6 to 12 o'clock position. We have calcium here, which is almost 180-degree arc of calcium. Now it's almost more than 270-degree arc of intimal calcium, but stent looks well dilated.
This is the site of stenosis.
Well opposed. That's the point where it was the narrowest. And we can see calcium. It's always more than 180-degree calcium, which is intimal. We can see so much of acoustic shadow beyond calcification. Once the run is done, we will do a small calculation at the narrowest point. We are yet to reach the proximal reference. As far as opposition is concerned, stent looks well opposed throughout. We are reaching proximal reference.
It did.
Proximally, it is well opposed and well dilated. So we are out of the stent.
Good. Okay, let's give us the MSA.
So
and we're going to post dilate the middle area anyway, because we saw that although it is expanded or opposed, I would say that we can achieve a little better expansion.
Vessel looks 4-0 on IVAS.
Huh?
Vessel looks 4-0 on IVAS.
So MSA looks like slightly more than 6.35 millimeter.
Okay, good. Our goal is minimum 6.5. So we'll just do this one and then we'll get ready for other side. We are dilating here with the good. Yeah, good. Okay, let's go up here. Go 24.
Shamin, I have got a question to you. Dhiman here. Do you find any difference between OCT and IVAS? Because now we have got a very high precision IVAS, HD IVAS. Do you find any difference between the two in dealing with this highly calcified?
That's a very good point. So question is, so to me, biggest advantage of the IVAS is we know exactly to actually not the quantity, but qualify that, basically saying which one is the calcium negative. In the OCT, of course, we can always see that rounded shadow and you can quantify, but that's an easy way. Although we cannot say thickness.
15-20.
Yeah. So we cannot do the thickness in the in the IVAS. But to me, when it is the only issue about making a diagnosis of calcium, IVAS, high definition IVAS is my preferred approach. For stent opposition, seeing the dissections and so, then is the OCT comes in. Go. And I would not just do the one. They're doing a little extra here. That's good. That's good. That's good. Go. Yeah, go.
And Shamin, to inform you, we have got at present 650 viewers on the show.
Very good.
So greetings to all the delegates who are participating in this great meeting and a great show by Dr. Shamin Sharma. Wonderful exposition of a highly calcified lesion and how to deal with it, just copybook way.
Okay, so let's take a last picture here.
Yeah.
The guidance a little bit. No, let's give a little nitro. So last picture, before we going that to keep the dye, conserve the dye in this patient, the nitroglycerin. I still want to leave the wire because in case there is a perforation and you have to put
absolutely. Yeah.
So we just the guide is okay. Okay, fine. Okay, so we are done here. Go to the left side now. Right looks very good. Why? Good.
Yeah, it's beautiful result.
Yeah.
Beautiful
so let's
result.
continue.
Excellent.
Give us about 2 minutes. I'm going to get our left-sided guide ready, and I can tell you the audience number will increase once they see the calcification and the intervention of the left side now.
Yeah.
VL3.
So our faculty members, any comments from anybody? Dr. Jaspal, Dr. Anil Misra,
and I think you can ask
Rai, Dr. Das,
and ask
any comments?
And ask the faculty also about about this OCT versus IVAS. And I know that this is another field which is going to explode in next once we get some trials. Knowing that the IVAS trials all coming positive so far, we still have to have a OCT trial making difference in terms of lower event rates. iLumen and iLumen 4 will take another few years to show the results. And the Forza trial, which compared just OCT versus FFR. Initially, the cost-wise, OCT was better, the FFR was better, but at 1 year data showed a little better outcome with the lower MACE rate with the OCT. So, but IVAS OCT controversy, I would say that just has started. Both technology getting to the next level.
I mean, sir, I am Dr. Sharad here.
Yes, Sharad.
Yeah. Sir, what's your opinion about using OPN with ROTA?
That's a very good point. So I think say very clear that this case after ROTA use if you wanted to use opium balloon, which is completely fine. Epicranial, go epicranial only. Yeah. So this one could have been a combination. Idea would be that you want to just use one balloon after. So in this particular case, had not shown this combination of a rota cutting balloon in this particular case, I would have just gone in, let's say, not doing the live demonstration of this in my regular life. I would have just gone with a high pressure 3.5 or 3.75, put a stent and post dilate. So now we are taking a picture here of the left system. Good. Give us the fielder fine cross. The rotawire will not go. So this kind of complexity, look at the diagonal. This you can try rota, but it will can create a lot of trouble. So this is the kind of case I would say compared to the previous one where we went directly. This one will do a change it with a fielder fine cross, and I mean basically or use a run through, but use your over the wire system to change. Yeah.
I'm Dr. Jabir. Dr. Sharma, would you prefer to do an imaging prior to decide on a strategy in this left system? Because this is a long segment disease. There is a bifurcation lesion. You would like to know what are the characteristics of the calcium and what should be the proper, because calcium management, it may not be a single one. It may be a combination of strategies. It could be a balloon strategy. It could be a balloon with a cutting balloon strategy. It could be a rota strategy. It could be a rota with balloon strategy. So multiple strategies. It all depends upon what type of calcium, what is the extent of calcium, the morphology of calcium. So would you like to do an imaging prior to your
so very clear cut. In this particular case, knowing that what we learned on the left side, groin is okay. Yeah, what we learned on the left side, that from the calcium point of view, that clearly that I would not be surprised there will be any different. And we will know by movement of our catheters and so. So yes, I would say that we have the IVUS ready, but the goal will be that we go, because if you try to this diagonal and we have IVUS does not go and roughed it up, then it will going to create a more problem and than anything. So this case, I would say that let's get to the diagonal. We use a small burr there, because once we cross, we'll use a 1.25 burr, heavily calcified. Play that picture again, please. Now see this now, heavy chunk of calcium. So, and so question will be, you need to do a rotational atherectomy. So there is, again, some people may decide based on IVUS, and from my point of view, once you have that kind of calcium, there is no need. The IVUS is not going to add to decision making. IVUS can, in the process, IVUS may help to decide what to do and not to do further.
And here, are you committed to a two-stent technique? Are you committed to a two-stent technique?
Yeah, so that will be a good point. So the first we are doing the diagonal. Then we see this now. Even your fine cross did not make a turn. You see this now? My field wire is there. Even fine cross did not make a turn. So that speaks for this again. That
and the catheter is getting dislodged.
It requires a rota. Otherwise, I don't think any device is going to pass that point.
Yeah, that's correct.
Dr. Samin, and you're going with a 1.25 burr into that diagonal, isn't it? Your plan is to take a 1.5 burr.
Yeah. So question is very simple. You want to create a thing which causes less problem. So if your device has a trouble or does not go further, then you use a 1.25 bar. So this is the case, that is what we have published. That is what we do. This is the case. I'm going to use a 1.25 bar. We are going to attach 1.25. We took out the 1.75. When we work on the LED, we'll go with a 1.75. But for the diagonal, 1.25 is the one preferred because of we could not advance. Now, even the advancing the wire now will be tough because I could not advance my catheter further. So you use the rota clip. No, not yet. We're not ready yet.
Dr. Samin, I'm Nitish here.
Yes, Nitish.
How do you plan between the two vessels, like you have a LED diagonal in this instance? Which one would you like to rota first?
No, I would say that we go through the proximal LED going to the diagonal, and because lesion is more proximal. And so
You are going to you are going to do the rota to the diagonal means it is a two-strand strategy where you are going to stent the side branch first and secure the side branch.
Yeah. That's the question will be that if the ostium is not involved, which I think is not involved, we probably will do the rota of both prox with the 1.25 bar LED as well as the of the diagonal, do the PTCA, put a stent in the diagonal, ostium is not involved, looks like that way, and then we do the second stent in the rota and stent in the LED. So that will be the strategy.
So yeah, you are also concerned about the cost of the therapy because here there is the RCA, then we require two different rota burrs here. So would you like to consider a 1.5 burr as a workhorse wire for both the diagonal? Diagonal also seems to be somewhere around 2.5 to 2.75. So can we use a 1.5 burr for both the vessels?
Yeah, so very good point. So question is, we already use a 1.75 for the RCA.
All right.
So we'll going to use the same burr in this case. Yeah, but you're right. But I would say the other way around. If I had to choose one burr, knowing that we are having a trouble in advancing our devices and wire, I'll go with a 1.25 bar only.
The only issue with the 1.25 bar, we are all afraid is a stuck bar can be more of a problem with a 1.25 bar rather than with a 1.5 bar.
Yeah. So, but this kind of angulated vessel will give more trouble. See this, and that is where the problem with this rota wire comes. The rota wire is not that user friendly, and it goes into that small branch.
This is the rota floppy, isn't it? Not the rota link plus.
No, rota floppy, and the wire even. Okay, let's get a run through. Maybe it goes a little further, because we need to cross this so that rota wire has no. Because what happened is because of transition of 0.014. I mean, I think this may be enough room.
Yeah, now it's.
I think so. Yeah. That's right. Good. Okay, we are ready with the 1.25? Okay. Yeah, so in this case, let's say if the cost would have been the issue, that's okay. Use a 1.25 both for the proximal LED and for the diagonal. And then what you do is you just do a balloon, high pressure balloon or your opium balloon and open NC balloon for the proximal LED, and you don't need to upgrade the bar. So that will be the second strategy in this particular case. But in this case, we already have a 1.75 bar with us, which we use for the right coronary. And we might just use that also after doing the ablation in this very complex tortuous diagonal.
The LED seems to be a little bigger vessel, seems to be at the proximal part, it seems to be a 3.5 millimeter vessel. So will the wire buys maybe be a problem when we use a 1.25 burr? Can it cut?
No, but I say that we want the rota to create a cut in the interelastic lamina. That is perfectly fine. And as long as you don't lose the wire and your subsequent balloon, you are following it, that how the balloon is expanding so that you don't have to rupture the vessel. So you see the subsequent movement of, I know a lot of people are concerned about this 1.25 bar, but I can tell you in these tortuous cases and these tough cases where you cannot get anything else down, 1.25 actually has been a very good bar, because just what it does, it cuts the plaque a little bit, and then your rest of the work can be done easily. Now we had to have ready balloon, 20 balloon for the diagonal. So we are ready with the 1.25.
Then we can use 1.75 bar for the proximal
LED, yeah. And the same, because we have 1.75 bar there, and we can see eccentrically, you saw it, the lesion in the proximal LED is also significant. Yeah.
Proximal LED.
So we'll try to use all those which have been used already. So not add cost to the device, but yes, in any time when you feel like that lesion is not opening up and want to use IVL, which is perfectly fine also. Okay, we are ready to check the speed now. 155. Good. Okay. We are ready to rock and roll. Let's see. Now you can see my wire is very unstable distally. But push and pull is still required because over the wire system, they don't have any monorails yet. Good. Okay. So once it is, you adjust your field, which you will be working. Your guide should be there. And then a little bit, you can just advance left and right. Good. So same three steps. One, then secondly at the Y connector, and then at the clearly just little Dynaglide. No. Okay. So we are ready now. Starting. Yeah, LED will go without any problem, as we know. Yeah. Yeah. So we expect that 1.25 will give us a little trouble, as expected. And I always say that your post dilatation balloon should be ready on the table. In case you have a little trouble, your wire should be ready, your post dilatation balloon should be ready. In case you have some perforations and so. And of course, try to do 20 seconds run, and still there is no 1.25. Now, once this does not go, other options definitely will not be the IVL. Other could be the laser. Although any calcium where we could not do the rota, laser never helped us. Yep. So far, hemodynamics, as you can see, little blunted pressure, but pressure is still more than 100. And we have our anesthetist colleagues to.
শোনা যাচ্ছে না in between বুঝছো শোনা যাচ্ছে না পুরো অডিও অফ হয়ে আছে
Link is not there.
অডিও পুরো অফ কি করে দেখো
Raghu?
তোমরা শুনতে পাচ্ছ
So, sir, their network is breaking.
Audio is okay.
Yeah, their network is breaking from their side. They got cut off.
Oh.
So.
Anyhow, Dr. Shamin has been showing a beautiful. Yeah, Raghu, please look into it. We can't see anything. You know, we can't listen also.
Yeah, they have to reconnect, sir. I'll talk to Jaipur now.
So kindly support from your side because I think we are totally disconnected.
Why?
Yes, now they have come back.
Yeah, we can see. Yeah, we can see and we can listen also.
All right, let's come back out. We're trying to understand what is happening because we keep, my limit is about 3 minutes and we are done 8 of the 20 seconds, just about. So we are going to come back out and see where we are. Keep the wire there. Okay, give me that fielder wire.
Just come out.
Not yet. Good. Okay, we leave it everything. Close the flush. And let's see the situation. So what do we have? that fielder. Because clearly once you start burring even at high speed and you have trouble, you want to make sure that there's no perforation or so. Good. So far, so good. Okay. Let's give the run-through wire again. The fielder. So give me the fielder wire and let's get a 1O balloon. So key is that we are done. And I also say many times you have gone through the half of the calcium. So you may have enough break that you can get a small balloon there. Yeah, give the one. 1 or 1.25?
1.25.
Yeah. Or get a 1O. Once we are going.
1.0.
Yeah.
Showing a crossing the lesion.
Yeah.
So you are taking 1.25 or 1?
Which one we should take? Tell us. We are still thinking.
The balloon. Yeah, I think 1 into 5 really will be a good choice. Yeah, it's a very
good 1.25 balloon.
Yeah, 1.25.
Yeah, okay.
When we are doing balloon angioplasty, will it not be a good idea to put another wire into LED?
Oh yeah, no, we don't. No, but I think I'm not done with the rota, and we might end up in doing a little additional. Remember, there is a proximal at the bifurcation, and then there is a little further down. So the question is, let's show the picture, last one. Yeah. So what will it be if we get a little balloon here? I'll bring the rota wire into the LED, and that's where our goal will be, to do a 1.75 bar for the LED. And worst come worst, you can leave the diagonal alone, in my opinion, rather than risking a perforation. And we are done. What our techniques are available.
Yeah, I think that is not a bad idea, because the diagonal is a 2.25 to 2.4 artery,
exactly.
And it will not
Good.
be unwise to keep it alone here.
Yeah. This is, as you said, it's the 1.25 balloon.
Yeah.
There's a heavy calcium and a
Negative.
small balloon. A little further.
Go up. Now we get a 2O balloon, or what do you want? Non-compliant, 2 or 20. 2 or 20 non-compliant.
So one more dilatation, just approximately.
Yeah, go up here. Yep, negative. So 1.5, 1.25 balloon did the work, and see, same thing. As I mentioned, that don't have to get rota in a complex case and keep burring and cause perforation. So you have done the work partially, you have cut the calcium, that's okay. And then you supplement with the your balloon dilatation. Okay, so now we are going with a 2O20. What is it? 2O15, non-compliant. Okay.
Yeah.
Good. Okay, this is the 2O20, high pressure. Go up. Right here. Yeah. Negative. Open nicely. Even see the partial cutting of the plaque with the rota did the job. 20. Negative.
So it's a combination of different modality while you are going for the plaque modification and such
Yeah, the proximal part didn't dilate well, isn't it?
1 second. Okay, let's go back again.
Dilatation.
Yeah. Right. Little die. You're okay here. Yeah. Go up.
Yeah, right at the ostium.
Good. Okay. Negative.
So what is
no,
the
but we can
opinion?
put
Should
the
we
stent.
go for the
Play the last one. I think we here. Yeah, let's bring the rota wire out and put a rota in the LED.
Yep.
Again, this once you have this calcium and the wire tip is always a trouble. You may have to go back. But I think this is the case. We are going to do a stent in the side branch first.
Groin.
Yeah. Okay.
You have to find cross.
Yeah. So we are going to use that. Take this one out. But we can bring, let's show the picture again. The diagonal, can we just bring it to the ostium and not covering the ostium, which is okay.
Feeler will find cross.
Okay. So you see this now. So yeah, we are going to go, little see. Ostium is okay. Let's get a 2.25. What is strength length we have? 28 or 32? 32. Yeah. Give us 2.25, 32. Promise. Okay?
Yeah, groin is fine.
Yeah. Good.
But he's moving around. That's why.
Yeah. So we are putting a stent, and now we are going to wire the LED. And I know that we are reaching the time for our live transmission, but let me put a stent in the diagonal, and then I'm sure the LED, if we may have a time, we could show back later. But we finish this complex diagonal, which is nicely opened up with a balloon, and now we are going to put a
very
stent.
nicely opened up. Yeah. There is
And
just
again,
chunk
I
of
wanted to
calcium, and you have done an extremely good job. Yeah, extremely fascinating one. And what is your opinion, Shamin? If you leave it on balloon alone, you were talking about that. There is TIMI-3 flow. Of course, the stent will improve the situation. And if you put a second stent in the diagonal, what will be the strategy of yours?
Yeah, so very good point. So case right now we are putting a stent. Yeah, right now we are putting a stent, but not with a Medina, knowing that the side branch ostium was not involved. But you're right. In this particular case, again, we don't have that much experience. I know some people, and one of your, actually last week's Dr. Arneja's conference, the Colombo was making the point that many of these small vessels, they are just doing a cutting balloon, I mean the drug-coated balloon and leaving it.
Right.
So that is another strategy, but we don't have that experience. So I would just go with the stent. If there is any adversity with a stent, then only we'll just leave it with a balloon only. So now you always see that your wire should be there, good little die. So we go few millimeter off. This is the Promus Elite. Good, go up. Get a nitro ready. Negative. Go up again. Negative. Yeah, just go 2 atmosphere. 2. Yeah, we're going to take a nitro, take a picture, negative. Guide out. Okay, let's give nitro. Take a picture, and we finish in time for your next session, which will be their combination. We are still live, correct?
Yes, yes.
Good. Okay. Good. Okay. So diagonal looks quite well, and we are going to take care of the LED now. And LED we put it across, and if there is any question happens, we can go back to the LED stent struts and open the ostial diagonal. Yeah. Okay. With that note, I know that you can continue.
Okay, we can come back to you, Shamin, if it's possible from the tech team to see the end results. Okay.
Make sure we continue to record.
You are going to stand the LED as well. So beautiful result. There was some chunk of calcium. And you know, you have done an extremely good job, Shamin, and your team. So congratulations to both Shamin Sharma and Dr. Sanjeev Sharma and his entire team. And please come back later to show the final result. So it's a fascinating story how you did the RCA highly calcified lesion using 1.75 bar. Then on the left hand side diagonal, which is nothing other than a chunk of calcium again, and how you did the job. It's really to be learned from you only. Thank you very much, Shamin.
Fantastic.
And we'll be coming back to you again after you have the final result.
Yep. Perfect. Sure. Thank you.
Now I am going to show a few CTO cases, what we have done during the last 1 month or so. And so can we go to the,
Yeah, put a 1.75 bar there.
First one. Good. Yeah. First one.
Yeah. looks okay. Now rotor wire.
Dimanda, you are muted.
Sir, your audio is muted. Sir, this is from the back end. Your audio is muted. Sir, your audio is muted. Please unmute. Sir, please unmute your audio.
It's done. So during the next few minutes, good evening, ladies and gentlemen. We had a fascinating session with Dr. Shamin Sharma and Dr. Sanjeev Sharma from Jaipur, and they have shown how we have to go in a highly calcified lesion. And now I'm going to show a few CTO lesions which we have done during the last 1 month or so. This is a story regarding a 62-year-old normotensive diabetic non-smoker, normal epidemic individual admitted to DM Birla with crescendo angina. He had an anterior wall MI some 1 year back on 4th of April 2020, and he was admitted to hospital out of Kolkata and had double vessel disease and has proximal LED 100% occluded, but no revascularization was done at that time, and LED was the IRA. His echo showed LVF 50% with mild hypokinesia of the anterior wall apex and anterior IVS, but the scar was not that big as it happens in proximal LED occlusion. He had a CAG done in nearby hospital, which revealed double vessel disease. No revascularization was done, but the patient has been experiencing crescendo angina for the last 1 month. An ECG showed evidence of anterior myocardial infarction, old one. So now the LED lesion is a CTO one, and we proceeded with a micro catheter with BMW wire, and then it changed with a Gaia wire. So these were the sequence of events. We won't detail it, and this is the angiographic picture. You can see that the LED is 100% occluded, and I can't tell that it's a very favorable lesion because there is a diagonal you can see, and the tendency of the wire will be to go towards the diagonal branch. So anyhow, we took a, you can see in both the views, the subcostal and the other views. And this is the RCA. It has also a lesion. And we did the RCA because it was not a fresh MI. And we have done the job, and it was an easy one. So this is the final picture on the right-hand side after putting a DES stent. Now the story, we went with a micro catheter with a BMW wire, and after reaching the tip of the lesion LED, we changed with a Gaia 2 wire like Shamin has been using over there. It's a very good wire, I should tell, but you can see that it took about 25 minutes journey to cross from the proximal stump to the distal one, and reaching the distal stump, it was very difficult. You can see the buckling of the wire in the middle one, and the right hand side showed that finally we could cross with some twists and turns. And Gaia 2 is a good wire, I should tell. And then we dilated with a one pipe Riori balloon. That is one of the best balloons which we use. We take a non-ETO one, it goes easily. And we dilated, and then we dilated, post dilated with 2 into 15 millimeter balloon. And this is the flow, as you can see, after dilating with the balloons 1 into 5 and then 2 into 15. And then we have put a stent from the ostium of the LED. And you can see there is a nice T3 flow with also good blush in the territory. I always look for the blush in the at the end of the vessel, because that's very important. We can see the septals also. And this one is the second lesion, and the patient has been completely asymptomatic since then and was doing well. This is the story regarding a 60-year-old diabetic normotensive lady, crescendo angina for 3 months. ECG shows T-wave inversion in the inferior leads. Echo showed no regional wall motion abnormality with good LV ejection fraction. She undergone an angiogram which showed CTO in RCA with bridging collaterals, because presence of bridging collaterals tells that it is going to be a little difficult lesion. And myocardial viable assessment done, and it was a viable RCA territory. Plan to open RCA. Of course, the echo was normal, but still, and you can see that the lesion had a lot of collaterals over there, and there is no channel visible. You can see some zigzag, small arteries which are connecting, but there is no track as such between the proximal and the distal segment. So we took a microcatheter and changed with a BMW, and we changed with a Gaia 2, but it was very difficult to pass the Gaia. Anyhow, we could finally cross the lesion, and it was also a 25-30 minutes journey, but then everything was easy, and we passed the microcatheter down, and then we dilated as usual with 1.5 Riori, and then with a 2 into 15 millimeter balloon. And this is the result after ballooning. And subsequently, we have put a stent, DES, and this is the result, but it could not cover the entire portion. So we went for some dilatation with a balloon. And this was the end result you showed. This is regarding one patient, Ashok Das, who came with ACS, and we found that the LED has a CTO lesion, and he has been suffering from the angina for last few months, which have increased very much recently. And it was again a very difficult one, because you can see that from the proximal, this occlusion, this LED occlusion, there is a big LED branch and the tendency of the wire, and also a septal branch. So either the wire was going towards the LED or the septal one, and we cannot see, even with retrograde ejection from the radial, that right radial artery, that we couldn't find definitely where was it coming, because the term, the retrograde filling was also not very well. So anyhow, we took a microcatheter and then changed with a Gaia 2 again. And with Gaia 2, it took a long time. And this almost took 40 minutes to cross the entire segment. And it was a long lesion. You can see the side branch.
Louder.
Diagonal. Yeah, can you listen, Mrinal,
Yeah,
now?
I'm listening, but
Yeah.
it's very
Yes, we can.
Okay, I think there is some audio problem. I talked to Raghu just before the lecture, starting the lecture, and this is the final result.
Just
And this is the final result. We put a long DES, And you can see the septals, beautiful septals. All the septals are visible. Good blush, good T3 flow. And we did some post dilatation of the stent, long stent, and I think it's acceptable result. And this is another case. This is a 75-year-old lady, had heart block. We put a pacemaker first, and then dual chamber pacemaker with septal pacing. And then you can find that the LAD is occluded, and we did the RCA first, of course. And this is the LAD. You can see that the proximal cap of the LAD where to go, and exactly at that place there is a diagonal, large diagonal again, compensating for the occluded LAD, and it is a CTO lesion, because you can see that there is beautiful retrograde filling from the right coronary artery. So anyhow, we blindly went with microcatheter support again with the Gaia 2 where this is our very favorite where, and we could go to the distal cap. It was also a hard one to cross the distal one, but anyhow we could, and this was the where. And finally, as usual, we did with a 1.5 Riori balloon, and again then we took a 2 millimeter balloon, dilated it, and put a long stent. So CTOs are not always very difficult to perform, and provided we follow the book teachings with patience and preservations. However, in some cases, of course, ADR, retrograde approach, these are required. But one thing, we should not go for dealing with the CTO lesions ad hoc, because we should study the lesion well, and if required next day or after 1 or 2 days, we can go for dealing with the CTO lesions. And if we see the lesions well and we have a plan in advance, I think many of the CTO lesions can be dealt with well. And but patience and perseverance are very important, and we should have to avoid long fluoro time, and also a lot of dye. So thank you very much for your patient hearing, and I would love to have your expert comments about these few patients.
Put a wire in the diagonal.
And we'll come back to Dr. Shamin Sharma to see the end result.
Yeah, Dr. Kahali, all the 4 cases are really beautiful, and you have performed really all the CTOs successfully. Only one question remains, that unlike the first case,
any other
case we could not see the collaterals. So what could be the explanation?
Oh, sorry.
No, I think you saw the collaterals, Minal, in the second case, the RCA lady case. That case we could see the.
You give us the stand.
We could see the collaterals, but all the cases were very hard CTOs.
All were in 3.5.
And you could see how much time it took, to cross all of these lesions. And we had to take the microcatheter support. And in all the patients you saw that the wires were buckling, even Gaia was buckling. And that shows that how difficult it is to cross this one. And I remember in the first and third case, it was really very difficult to cross even the distal lesion. So, you could show the retrograde filling, because unless the lesion is a quantified CTO lesion, you won't see such beautiful retrograde filling. And because of these are the CTO lesions, you could see where the big diagonal and septal branch, big septal branch was there in 2 or 3 patients. After that, the dye didn't travel. So it was really very difficult, both the proximal and the distal cap. The journey in the middle is not that difficult, of course, but I won't tell, because and to manipulate the wire in such a situation is also very difficult. In third case, I knew I was going to enter the LAD, but the tendency of the wire was always to go to the diagonal branch. Anyhow, we could manage it. So we always keep a watch on the total fluoro time so that it doesn't exceed too much. Total dye used, just like Shamin has been showing a beautiful case, 80-year-old octogenarian gentleman on whom he is doing with a creatinine is high. And what we do, sometimes we do a USG of the femoral artery in such patients with CKD or borderline CKD and the common femoral vein, and follow the rules so that the patient is properly hydrated or not, because sometimes we find that because of some pre-renal factors also the patient's creatinine is little elevated. We also go for USG in such patients, and he has been dealing with an extremely bad patient. Usually we get octogenarian gentlemen or ladies like that, full of calcification, chunk of calcium, and along with that, you know, and along with that, you see that the patient has CKD and other comorbid condition, as Dr. Sharma's case is. I would really give him a very big hands because it's a beautiful case. Any more comments, Joshpal, Dr. Devabrata Rai?
Sir, this is Devabrata. Hello.
Yeah, I can see you.
This
Yeah,
is
Devabrata,
Devabrata.
please tell.
Yeah. Sir,
Yeah, please tell.
do you have any experience of IVAS guidance during CTO wiring?
Yeah, you see, we do it, but not frequently. I should be very frank and honest, as Dr. Shamin was also telling, that this helps a little, but as a whole, we use it in 5 to 7% cases in our country. And I was asking the stalwarts in Europe also that in how many cases, even in difficult bifurcation, like Goran, I was asking, he was telling 7 to 8% of the patient. And majority of the patient in European countries also, they don't use IVAS frequently, because it is from our experience, if you take a good microcatheter with a software support, you go up to the proximal end of the proximal cap of the CTO lesion, and then change with a, Gaia 2, Gaia 3, etc. We are fond of this where, of course, Gaia Next is not available, because Gaia Next, the tip load is 9 grams. And Shamin showed a few cases. On that day, and he was from Mount Sinai, we were together, and the Gaia Next is available over there. Hopefully, Gaia Next is coming to our center also very soon. So I think that is sufficient, and but IVAS guidance is sometimes necessary, but we don't do that frequently because of the financial reason, nothing else. Because of microcatheter, fresh balloon, because we have seen that unless you give a new balloon, sometimes you lost the wear also, because you go with a Oxford balloon and those are so sticky that it pulls the wear and everything is out, and then you have a difficult one. So to go through that course again.
Dr. Zimmerman, in all your 4 cases that you have shown, you have used a Gaia 2 wire. Now, how do you?
Yeah, I'm fond of Gaia 2. Yeah.
How do you decide which wire to start with, and how do you escalate your wires in a CTO?
Yeah, see, we have a bad tendency. We change with because majority of the patients we have been seeing that Gaia 2 is a very good wire, and we have been doing well. So we are fond of this wire, but suppose Gaia 2 doesn't work, then we go for Gaia 3. And if it doesn't work, then we go for Confluenza Pro or Conquest, whatever. That's with 12 gram tip load. But we want to avoid those kinds of wire, and we go majority of the patients anti-grade.
Sir, in presence of bridging collaterals, does Gaia 2 steal your wire of choice? In presence of bridging
first take
collaterals?
it. If it doesn't go, I would have taken Gaia 3. And if it didn't work with microcatheter support, we would have gone for a better wire, that is the Confluenza Pro with 12 gram load, Conquest Pro. But seldom we have to go for Conquest Pro, because you saw that second case, the lady's case, Parvati Devi, it had a lot of collaterals, and we are very apprehensive that whether we will be successful or not. But at the end of the day, we could go, and it took, of course, 20-25 minutes of fluoro time, but with a good microcatheter support. And Devabrata, I would like to tell you one thing, that it makes a hell and heaven difference if we take a new microcatheter with a new Gaia 2, and if we take an old microcatheter and an Oxford Gaia 2 also, it makes a lot of a difference. And I have been doing with new patients, and I can see Professor Gary Minch. So welcome, Dr. Gary Minch, to our webinar. Thank you very much for joining us. And would you tell something? Devabrata was just now asking that what is your message about passing the wire in a CTO lesions where we fail with a Gaia 2
Closer
with
going now.
IFAS guidance? How much does it help?
Camera away.
Your expert comments.
Like anything else, it depends on your experience and whether you take the time and the effort to learn how to use the images and interact with the images. The answer in a simple way is that if you have trouble entering the native CTO vessel and you have a place where you can park your IVUS catheter, it can even be a small side branch, and you're comfortable and familiar with the technique, it helps a lot.
Thank you very much, sir, for your expert comments. Can we go back to Raghu? Can we go back to Dr. Shamin Sharma?
Okay.
Because he will be showing us the end result.
All right, we are ready to show.
Shamin, we are back.
Yep, and we are back here.
Yeah,
we just completed. Yeah, give me the camera.
Okay.
Yeah, I'll
So
tell you.
Just would like to see the end results. Yeah.
Yeah, so let me take you through where we are. Okay, we left you here.
Yeah, yeah.
Which one? Play. Play. Good. So see that. Yeah, this one was where we left you. Then we put a wire into the LED, 1.75 bar. Then post dilatation. We left the wire in the diagonal. When we are dilating and putting the stent in the LED, and you can see here approximately we made it exactly, and this is where we are. End of procedure, ostium completely covered, all done. All branches diagonal, we didn't need to do anything to the ostial diagonal. TIMI3 flow, little mild narrowing, which is okay. Yep.
Yeah,
we
yeah,
left it here.
absolutely.
Patient is
Okay,
fine and
because there is
completely fine.
blow with all the branches visible. So
Yep.
what more do we want? Only there is little pinching that is well acceptable.
Which is okay, acceptable.
The
That's where
size
we.
of 2.5 millimeter. Yeah.
Yep. And we, with that note, we ended this complex case of 3-vessel rota, the diagonal LED and RCA. And thanks our organizers of NIC CSI to give us the opportunity and showcase the step-by-step approach. I would say every case is a learning case. If somebody says, what did I learn? And what did I contribute to other people who watched it? One is that you try to use the technology as much as possible, but don't overdo it. Keep burring for 3 minutes and perforate the vessel. What you do is you did your work as much possible, you took it out. We did it out and then use the balloon, because even your some crack in the calcium wall will allow your subsequent intervention very well. You saw that we could not get fine cross. We were able to dilate with the 1.25 balloon as Dr. Deman suggested and put a stent. So the key is that as long as you went with a strategy, but don't overdo it when your limit is that, like we do maximum 180 seconds of ablation time. When that passes, more chance of perforation flow occurs. So just don't do it. That stop there, because that will be less harmful than doing it further. And final is same, that mild results here and there could be okay. In this particular case, 80, patient 70 plus years old, not going much die. We wanted to avoid putting a kissing stent. Since ostium was truly not involved, I know that can be confirmed by the IVUS, but key is that overall everything looks good. We gave very small amount of dye for this 3-vessel intervention, and we stopped here.
This is a brilliant piece of work, Dr. Shamin Sharma. And we, on behalf of CSI NIC, congratulate you, Dr. Sanjeev Sharma, and your entire team from Jaipur for showing us a beautiful case, which is a beautiful learning case. And all of us learned from your beautiful technique how to deal with a almost undoable case, how you have shown how easily you have finished within an hour or so. 3-vessel angioplasty with all the vessels at rotablation, pre-dilatation with balloons, and you have shown how to put the stent without any complication and after using the least amount of dye. So because the patient has a mild CKD and he is an octogenarian patient. Thank you very, very much, Dr. Shamin Sharma. Please give them a big hand. And
thanks,
it's
everyone.
a beautiful piece of work, and we must congratulate. And Dr. Shamin Sharma, I would invite you to be with us as a chairperson and moderator in this session and the next one as well, because your comments are very valuable to all of us.
Yeah, I will continue in this. What happened is I have another, my Mount Sinai, the commitment at which will start at 8 o'clock from here. But I definitely will be with you another half plus hour.
Yeah, please, till then, please be with us. And I can see Dr. Rustem Dotop, and please, I invite you. He is a noted cardiologist from Australia, and he's the director of cath lab there. And he will be talking on plaque modification with rotational atherectomy and next generation cutting balloon. So Dr. Rustem Dotop, please, and I would ask the same faculties to chair the sessions. And I also would request Dr. Gary Minch to kindly chair the session as well, and Dr. Shamin Sharma. So please start. Dr.
Thank
Rustem
you.
Dotop.
Thank you, Dr. Kahali and everyone. I hope you can hear me. So I'll try to share my slides. Can you see the slides?
Yes, we can.
Okay. So when we talk about plaque modification, these are the few tools that are available to us in Australia. And my first plaque modification tool, by the way, is actually imaging. And when we talk about calcified lesions, about CTO, about surgical turnedowns, etc., for me, it's IVUS, it's not OCT. And the most common plaque modification tool that I use, it's rotablation. Like in the previous case, we had just live case. Then I use a lot of OPN to deal with the calcium, cutting balloon, and the talk today about with cases about Wolverine that replaces flexatome. I use also drug-eluting balloons, like Dr. Sharma nicely showed this diagonal rotablation. I would probably consider long to 0 DEB there, with the rest doing exactly the same in the LAD. IVL is now also available for the past year in India. I don't have laser, even though we have machine for pacemaker lead removals, and CSI I think is coming to Australia soon. So IVUS allows me to know precisely what I'm dealing with. It allows me to choose my next plaque modification tool. And in fact, you can do the whole case, especially with CV CKD patients who is not on dialysis yet, completely without contrast, working in Braille, and just do the first and the final shots just for legal purposes. And obviously, the optimizing stent. Some of my colleagues just would use IVUS to check the stent after stenting, but the whole idea is to do it properly with IVUS beforehand. So my one of the main workhorse tools is OPN. I know it's available now in India for the past year. Works really good in combination with Rota or sometimes by itself. IVL is now also available. It's quite expensive in Australia, so it comes to also your decision making. But in the end, all this tool with plaque modification, is it making case more complex, or is actually making the complex case more less complex? So I will base my presentation on different cases. And this is my first case, elderly patient with osteofibrotic RCA with angina. This is 5 French catheter damping. Lots of GTN is given just to check if it's real or not. And it seems to be real. I use a lot of IVUS actually, because yes, we don't use Oxford, but you can do that. And in fact, even though it costs money, but it long term, I think it saves money because you do it properly and the patient's less likely to come back and you spend more money. So this is the guide now from radial I went femoral, or still I like usually go femoral. As you know, guide moves in the same direction with the ostium from femoral. And IVUS shows me that it is actually 6 millimeter vessel, but MLA of the lesion is quite small. So, and it's really fibrotic, it's not calcified. And cases like this, you can do whatever, NC balloons, OPN balloons, shockwave. Don't have experience with shockwave in fibrotic lesions, but here for me, it's a cutting balloon. So we still have a bit of left flexatome in Australia, but majority of them are Wolverine now. It's redesigned, it's a smaller profile, more flexible, and it still comes on NC balloon. So as you can see, the waist will be gone now, it's gone. It's 4-0 cutting. 4-5 NC to prepare it more to confirm that it's working well. 5-0 DES. So it's deployed, and 6 NC. And it's the final result. So lesions like this, if they are not prepared well, especially with cutting balloon or cell fibrotic lesions, within usually 1 or maximum 2 years, they usually tend to come back. And then it's more difficult to treat. So recently, I had a first experience with a 5 French guideline in Australia. Why I'm showing this case? To show that I could deliver 2-0 Wolverine to deal with melon seeding of NC to the old ISR via 5 French guideline. As you know, guideline, guide 0, telescope 6 French, inside there almost 5 French. So 5 French device inside is probably, I don't know, 4.3, 4.5 French. And you can still deliver Wolverine. Yes, it's small size, but you can. I'm sure Flexatom would not go. So that shows that actually the current generation device is much better and smaller profile. Now the case of IVUS regret, very similar in fact, non-STEMI, and I was asked to look into this right coronary artery. So retrospectively, I would probably do things differently, but I didn't take much notice. Yes, it's a bit of calcium there. So I went straight with ballooning to 0.30, seems like opening. And then I didn't do IVUS. As I mentioned, I do a lot of IVUS, but here it was kind of late in the evening. I decided not to. I thought, okay, let's just cut it with 3.5 Wolverine. 4-0 NC seemed to be okay. I had second wire as well, like Pullman's rotor, and then deployed 4-0 stent Megatron. And I realized after deployment that I actually did not prepare the vessel. You see, it's 6 French guide, it's 2 millimeter, it's almost the same size, but it's 4 millimeter stent. Luckily, it was Megatron. With Megatron, you can do a lot of things. It's usually is forgiving. Complete recoil. And then I really work hard on this. The thing is, if it's fibrotic tissue and if you didn't cut it with cutting balloon or you didn't make a cut on that ring with rotablator under different angles, and this is probably a scenario to use extra support wire. I usually use floppy wire. Nothing, I guess, can be done once you deploy the stent unless you keep stretching that. And that's what I did a lot. With ostial lesions, usually you protrude a couple struts to the aorta just to make sure cover. So, and in fact, this 4-0 stent, I pressed a lot with bigger NC balloons, 4, 4.5, and 5. And eventually it started, I guess, to look better, but still, I guess, not the best. And given it was Megatron, there was no fractures and I could see it well. As you can see, I use a lot of stent life, not stent boost, but stent life. It's one of the softwares in the Siemens. So that's the final result. And again, it's heart failure patient. All I needed just to fix the right coronary ostium. Kind of minimalistic approach. So retrospectively looking at this case, probably I should have done IVUS, realized that I need a bigger cutting balloon for 0, prepared better, or even go rotablation up front. Case like this, I quite often would do just rotablation. That usually also works. I don't know what's your experience. So talking about rotablation, technology has been again modified. And now most of the hospitals have RotaPro. Yesterday, I went to a regional center in Australia to do 3 cases there to Proctor because I got RotaPro. It's much more comfortable device. You don't have pedal and it's more controllable, more user-friendly. So looking at this case that I just showed, probably a rotablation would be good. It's very universal. It delivers what it promises and it's quite predictable. As you could see that Dr. Sharma showed 3-vessel rotablation. So we call it respect the calcium or it will come after you if you don't take calcium seriously. So this case, I like to show this case. It's a 59-year-old man who I call a rota regret case. So presents with this anatomy a couple years ago to my colleague. And when you look at the report, it's a lot of equipment. They went radial first, they went to femoral, used a lot of equipment, but not a rotor. And then they put two stents. One is 3.0, one 2.5. Just remember those stent sizes. It's the dominant right coronary artery in a man. So I call it harmful PCI, and you know it will come back. And it came back 1.5 years later with exactly the same symptoms. And the culprit is, we call it call from the past. Looks hazy, but you know that's a problem. So in cases like this, when it is severely underdeployed stent, of course, nowadays you can try to use IVL. This was case where IVL was not available in Australia yet. And this is the only scenario where usually upfront I go with pacing wire for rotor ablation. But here I try it without. Usually we pre-treat with medications, do short runs. And the stent waist was quite short. So I thought, let me do it without pacing wire. It worked, but much longer. All the stents I usually do pacing wire. So eventually it worked. I'll just skip that. And then I put, after pre-dilatation, put 3.5 stent. Remember, it was 3.0 up on the top, 2.5 in the middle. And now I put 3.5 stent, dilated it well. This is before and after. So this is typical case of rotor regret that will come after you later on, luckily, if patient just with a small non-STEMI. So always take calcium seriously or refer to somebody who can do it or invite the proctor. So I'll show a couple more cases. One of them I call rotor respect. All these cases just from the last couple of weeks. 68 years old with non-STEMI. A bypass was done kind of total arterial a couple of years ago. Currently LV is preserved and also had previous MI in the past. This is his coronary angiogram. So overall on the big scale, his circumflex is not too bad. Yes, LAD is bad in pieces, but his lima is working, as you will see. Pay attention to this right coronary artery that had radial graft to PDA. What do you think? Is it blocked or not? Just keep in mind this one. His lima, as it meant to work for 30 years, is fine. Distal anastomose is fine, but on the right picture, you will see the culprit, which is the radial graft. Radial graft also meant to outperform SVGs, but unfortunately, this didn't work well. And that's the culprit this time. So when you do single catheter reconstruct, you understand right coronary is blocked. But there is a to and fro flow. So it makes you to suspect maybe it's patent. So I didn't book it. Usually CTO cases, I book them as a CTO. Here I just went ad hoc, just added the second catheter from femoral. And you can see, in fact, it's not CTO. It's just subtotal, but you can just cross it and do antegrade case. But it wasn't easy. So I have 7 French AL guide, supportive guide from femoral with long 45 centimeter sheath, and Corsair Pro is not crossing the mid vessel. So what you do next is like a protocol for wire crossable device and crossable lesions. It's just reaches there and it doesn't go further. So I added trap liner when I expect a case where I do a lot of exchanges of equipment. I usually use trap liner rather than guideliner, Godzilla, or telescope, because it has already a balloon inside to trap equipment. Despite that, everything is backing off. So then I tried a couple balloons, 0.85 balloons, a Sapphire. It didn't work. Then I used 0.85 nano balloon, which is made by SIS, like I call it baby OPN, to 25, 26 atmospheres can go. Didn't allow me to cross again with Corsair. And what simple case, simple strategy left. is to try a small catheter, find cross, again, didn't work, and they just wedged it and buried the rotor wire. I just saw on the Twitter this week that in America they have new version of rotor wire that has been expected for some time. They said in Australia we'll have it end of this year. So that one you can, I guess, drill more, it's more friendly. This is just polishing runs after very careful several runs of 125. Because once you have rotor wire across, the case is done. And later with 3.5 in this final result. So unfortunately, when you do total arterial, you expect this arteries to stay MPGs, for some exceptions. And here the man lost graft to PDA. As you can see, it is filling back there, but it's gone forever. There is no point trying to recover this long disease in radial graft. That's before and after. So this was a case of device uncrossable lesion that was sorted with rotablator. This is, I call, rotor regret case. With rotablation, there are many rotor respect and rotor regret cases if it's not done properly. So this is a case with bad COPD done by my colleague a couple of weeks ago. You can see CCO of the circumflex, and you can appreciate that proximal ostial LAD is quite bad. On the big scale of things in this elderly population, I wouldn't usually think about this long diagonal. It's not the way the money is. It's almost if it's twin LAD. So here, you just confirm your findings. And the right corner is not too bad, and it fits that circumflex CTO, so almost natural bypass. So the case was referred for bypass, but was surgical turned down mainly because of bad COPD. And end up on my list 5 p.m. in the evening, so end of the cath lab list. Hence, I did exception. I usually always put a guide in the donor vessel, and I always wire it with the hose wire, so I don't have any problems with ostium, and I can always stand. Here, if you say it at 5 p.m., people will not like it when you mention the CTO. So I said, I'll just put 4 French femoral sheets very quickly and use diagnostic catheter for retrograde injections. So on BMW, I delivered Corsair and then filled the XT found the channel and confirmation of his retro. So you see, I didn't do any single antigrade injection. Once you confirm, you advance the wire, and then just a routine thing, predilate, 1.5 millimeter balloon predilatation, just to allow IVUS. And on IVUS, it was a tapered vessel starting from 225 distally up to 3, long lesion, and some calcium, but a lot of fibrotic tissue. So this kind of long lesions, I don't need to do rotablation here, but I like to do cutting balloon to prepare the vessel. So this is 2.5, and as you could see, it's maximum 3.0 vessel. With cutting balloon, similar like with OPN, I always go 0.5 millimeters smaller, especially in calcified lesions. Otherwise, it can cause perforation, which I had recently. So this is a single stent, 225 to match distal, and it can go to 3.5 proximally if necessary. Soft puff there, post deal, and kind of fix that. Given that it was late case, I just decided to try this antigrade in elderly. If it doesn't go, my aim was to just stent her left main to LAD and leave that circumflex alone because she's elderly. It's very well collateralized. So once crossed LAD, did IVUS again because I already had it open. So on IVUS, I had all the information I needed, that it was circumferential calcium. And cases like this, I usually use IVUS, but that calcium was very focal, circumferential, and I really thought, let me just get the same tools I had on the table. I used 2.5 Wolverine that I had on the table, didn't work, and then I used 3.0, as you will see here, and there is a huge waste. And of course, you cannot put stent like this. It will be bad long-term, even short-term. So then I took OPN 2.5. It was 3mm vessel, went to 40 atmosphere, and again didn't work. Usually OPN works in these situations, but it didn't. So I did a case actually yesterday in regional hospital where we went 1.5. Then we did everything else, didn't work. Then 1.7. You can think maybe there is by definition some dissections present, like extensive dissection, but somehow I decided not to use ROT in this case. So that's a ROT regret case. We had shockwave. Shockwave, it just kind of worked very simple on shock pulse number 7 out of 80. It already gave way, and then it was just putting a Megatron there, 3.5 distally, and optimizing it all the way to 4.0 IVUS guidance, just final result. So this case illustrates that I spent a lot of equipment, a lot of time, while I could just simply take 1.5 Roteber and just do the case much faster, save equipment, etc. So I have another case. How is the time? I think it's 20 minutes. Should I show one more case or not? Hello?
Yeah, you can see the case in short, yeah.
Yeah, okay. So this is just a 36-year-old man with positive stress echo. This is his LAD, a very small stump of LAD, as you can see, with ipsilateral and contralateral collaterals. And right coronary, you will see soon. So this is LAD reconstruct with single vessel as you prepare for CTO when it's referred to you. And you think it's probably short. And that's reconstruct. But when you bring the patient and you see here 3 months of medical therapy failed, and then he comes back. So it's by radial, left distal radial. And you will see that in fact, it's very short. And most of the time, just antegrade wire approach will work. So feel the XTR supported by Corsair went to diagonal, and then redirected balloon, workhorse wire, and IVUS. IVUS showed me that even though it's 36-year-old man, he doesn't have calcium, but it's so fibrotic. It's been blocked for some time. So again, for a case like this, to prevent long-term recoil and ISR, I like to use cutting balloon. It's very simple, just a few inflations. No injections here, after each inflation and so on. In antegrade, in CTO, you try not to inject. And then I think I used a biplane because all our labs are biplane. Usually for positioning, you do some injections. And then optimization port, again, and this is, remember, this is 36-year-old man. This is ostial LAD. That's final result. So again, cutting balloon here was very beneficial versus just NC, which pushes soft tissue to the wall. Cutting balloon allows to do cutting, and I guess it will have longer term better results. Okay, that's all from me, case-based presentation. Let's have questions if you have.
Yeah, thank you, Dr. Rustem, for your fascinating lecture and showing us all the beautiful cases, how you have managed and your decision prudence in all the patients. So I open the discussion and I can see Dr. Shirish Shiramoth. Shirish, any comments?
Yeah, in this last case, Dr. Rustem, LAD is totally occluded. You decided to use a flextome.
Wolverine, yep.
Yes, yes. So we do an initial balloon and then take a Wolverine, right?
Correct.
Yes. And how much you work before you take the stent? I mean, you do work with non-compliant balloon, make imaging to make sure that the stent will have a full expansion.
Yes, it depends on the case. In this case, it was 36-year-old man, and I was showed that it's mainly fibrotic soft tissue rather than any calcific. There was no circumferential calcium. So after 1.5 millimeter pre-dilatation and running, I think I usually take 2.0 NC to prepare channel beta. Then I took Wolverine 3.0, run it all the way through the expected lesion where I put a long stent. And I can see on angiography, on the fluoroscopy, that my balloon opens well. I didn't run another IVUS, I just put a stent. And then after that, I would do another IVUS and then optimize the stent with 3 or 3.5 balloon if necessary, and then we'll run IVUS again. Running IVUS is very fast, and it's always on the table. Comparing to OCT, I guess case like this, you could do OCT as well. But majority of complex cases where you avoid antegrade injections, IVUS is much better. And this is young patient. You want to do it once and properly.
Dr. Roy, any comments? Jashpal, Dr. Devabrata Roy,
yeah,
Dr. Anil Mitra is there.
Sir, in your first case, in one of your cases, a RCA ISR, where it was a 2.5 under expanded stent causing an ISR, you chose to do a rotablation upfront in this patient. Although the cause of this ISR is basically an under expanded stent, on top of it there is growth of fibrotic tissue. Why not high pressure balloons like OPN balloon, cutting balloon, and why did you choose rota here upfront?
Because the case, I studied the case, we record all the cases on the server, and it was done 1.5 years before me. I studied it well, and they used so much equipment, 3.0 balloons, NC balloons, everything. Nothing worked. Every time they inflated that, there was a waste. They even wasted 2 stents because they couldn't deliver that, and they damaged the stents. So that was the main reason. Of course, if it was done somewhere else and I didn't have records, didn't have films, of course I would put a better guide, support, maybe 7/8 French even for a case like this, body wire, and I would try to do NC balloons. The benefit of this was because I have information. I know there is a chunk of calcium, and they wasted the stent there, and I need something like rotational atherectomy. And my guide for that reason was just JR. I was 6 French, just to allow me to just slowly to go there.
So in such a case, like if you have already stented and it's an under expanded stent because of a large calcium down there, and IVL also could be a good option here. It could work across.
Absolutely. Absolutely. We didn't have IVL then. In fact, I have very interesting case, but which I like to show, where similar situation where 2 layers of stent in the old calcium, even then IVL didn't work. And then I still had to go and bring him 1.5 rota, 1.75 rota, and then 2.0 rota with spacing wire. Yeah.
Thank you.
So, Dr. Gary Minch, have you got any special message? So we have 900 plus delegates watching the show. And thank you, Dr. Rustem. We are 10 minutes late. Thank you very much for your excellent cases and also the messages. And we learned a lot from your great lecture. Dr. Gary Minch, have you got any small message in this sort of patients? How we can be helped by IVUS?
Well, I think that particularly in de novo calcified lesions, IVUS can tell you when you need to do some aggressive plaque modification. And I will show you our data when I give my lecture. In-stent restenosis is, as you know, extremely complex. Sometimes it's very easy, But if you have multiple layers of unexpanded stents, then it can become a nightmare, and nothing really works well.
Okay, thank you very much. So we go to the next session, and we have got very legend speakers like Dr. Gary Minch, Dr. Sanjog Kalra, Dr. Ramesh Dagubati, and Dr. Subhash Banerjee. And this session will be chaired by Dr. Sanjay Tagi, Dr. V.K. Bahal, Dr. Rajesh Vijayborgi, Dr. P.K. Shahu, Dr. Rakesh Jadhav, Dr. V.T. Shah, Dr. P.K. Goel, Dr. M.S. Siramat, Dr. Praveen Chandra, Dr. Neeraj Prasad, Dr. Dipankar Mukherjee, Dr. Keshav Murthy, Dr. Prakash Bir Parikh, and Dr. Sanjeev Sharma from Jaipur again. So may I ask Dr. Sanjog Kalra, I can see him. Thank you very much for joining us. He's the director of his cath lab, and he's a very noted cardiologist and very familiar with the Indian audience. So I don't need any introduction from him. So may I invite Dr. Sanjog Kalra for your speech. Thank you very much.
Thank you very much, Dr. Khalil. I am honored to have been asked to speak at the CSI NIC meeting. I'll just share my screen for a moment and confirm with you that you can see my PowerPoint presentation.
Yeah, we can see it now, Sanjog.
Great. So my task over the next 20 minutes was to show you a case-based approach to using IVUS and CTO-PCI. And my hope is that over the next little while, I'm able to illustrate how the way we think about using IVUS based on the data that we'll hear from Dr. Mintz is as a way of optimizing our outcomes. But in CTO-PCI, IVUS is a specific tool that perhaps is better or just as well used to actually allow us to get the cases done, the outcomes being the additional benefit of using it. This is the changing landscape of what we do, right? The old way was doing simple things, doing just as much revascularization as patients required, to now moving towards complete revascularization, where we do as much as is necessary to try to get our patients the best outcomes. And so the traditional use of IVUS in these types of scenarios is vessel sizing, plaque composition, stent positioning and sizing, perhaps outcome optimization, confirmation of adequate vessel preparation, and such. These are the things that we understand IVUS is for. But in CTO-PCI, we have to change our paradigm a little bit and realize that intravascular ultrasound isn't necessarily just to optimize the outcome, but it's actually to facilitate the primary motive behind the case, which is crossing the chronic total occlusion and allowing us to prepare the vessel. Now, we're all very familiar with CTOs, but in very brief review, there are 4 fundamental ways of crossing a chronic total occlusion. And I recognize that some of these terms, now that we have a new CTO ARC definition to define some of these spaces, are a little bit out of date, but just for the sake of simplicity, you can either put the wire through the middle of the plaque segment, i.e. antegrade wire escalation. You can go around the plaque segment, so either extra plaque or outside the intraplaque zone and then re-enter into the true lumen distally. You can come retrograde and go right through the plaque in retrograde wire escalation, and then you can use retrograde dissection reentry or reverse cart to be able to accomplish CTO crossing as well. But when we want to try to see differently, when we want to try to take the use of intravascular imaging beyond just optimizing the way we put in the stent to facilitating our crossing through some of these challenging lesions, we can broadly divide it into a facilitating crossing or defining tissue and anatomy type of approach. In the facilitating crossing, and we have things like IVUS-guided proximal cap puncture, IVUS-guided reverse dissection reentry. And fundamentally what this is removing ambiguity, which is one of the most dangerous things in CTO-PCI. The toughest thing that we do is to try to put sharp wires into areas where we're not 100% certain where the wires are going. And we all know that the cardinal rule is never ever advance a microcatheter or advance your gear when you don't know where your wire has gone. And so the use of intravascular ultrasound can really help resolve some of those ambiguity points. And then of course, there's defining tissue and defining anatomy. So sure, we've crossed the CTO, but where is it that we're intraplaque? Where is it that we're extraplaque? Where do we have dissection planes? These kinds of questions become extremely critical to obtaining the results that we want to obtain in these very challenging cases. And I know that in the previous, there was a question that came up about should you use IVUS in CTOs? Do you use IVUS in these CTOs? And there was some discussion around using the Gaia second wire and some of the more modern tools. But I think it's worthwhile for us to recognize as a group of colleagues that when we look at CTO PCI, which I love to do, it's the majority of my practice, we have pretty good evidence to show that they help symptoms. But the reality of the evidence around CTO PCI is it comes from largely complete revascularization literature. And it comes from the literature that says when we fix CTOs safely, we can get good results, but these are registry data. That's different than IVUS. When we look at IVUS in regular PCI and complex PCI, there are 9 randomized controlled trials, and they all support the use of this technology to optimize our results and to complete our cases with resounding accuracy. And so it's very important for us to recognize that if we're really doing what our patients need, we ought to be using intravascular imaging on virtually every case we do. So let's start with a case called Through the Looking Glass, which is a little bit of what we talked about here to facilitate crossing, right? This is about using IVUS to resolve proximal cap ambiguity. So here's a chronic total occlusion where we have a big chronic total occlusion of an obtuse marginal branch in the distal circumflex. You can see that there's retrograde filling from epicardial collaterals in the left-to-left system from this major ramus branch. Now, the problem is you've got a pretty flush occlusion of the proximal cap, and that's what makes it a little bit more difficult to figure out where to stick your wire. This is another view of that same obtuse marginal branch. It's quite large, but you know, is there a microchannel? Isn't there a microchannel? Certainly, it's quite a smooth proximal cap, and so it makes it a little bit more difficult to identify where to enter. This is yet another review showing that you've got a little bit of distal filling from the circumflex from the right coronary artery as well that was treated previously. So we try to define the precise collaterals that we can use. We inject down this obtuse marginal branch, inject into this diagonal branch. And what we identify is that we do have an ambiguous proximal cap, right? So based on the hybrid algorithm, this suggests that we should go antegrade. Suggests against going antegrade, but this suggests that we should go retrograde. But we have a pretty good distal target, right? So based on the hybrid algorithm, that leans away from retrograde and leans towards antegrade. But do we have interventional collaterals? Well, interventional collaterals are different in different people's hands, but ultimately these are epicardial collaterals, and those are always considered slightly higher risk collaterals than the septal collaterals we use. The data from large US registries certainly suggest that these are the collaterals that get us into significant trouble. So that might suggest, once again, against antegrade wiring in the highly experienced retrograde wirer's hands, or against retrograde wiring in the hands of the highly antegrade experienced operator. But the bottom line is we keep going back and forth. We don't have clear decisions based on the hybrid algorithm as to how to attack this type of a lesion. And so that's when IVUS can really become a little bit more functional for us beyond just figuring out how to land stents. It allows us to know where we're putting our wires. So this is a short tip eagle eye IVUS actually in this situation that is placed within a branch vessel. And then as we pull back, we're able to use that IVUS to identify the proximal cap in this particular chronic total occlusion. You can see that it's coming in here at about 3 o'clock, right? So we fluoroscopically co-register that with where the IVUS catheter lens is at that time. Then you use a microcatheter and a directed penetration wire like a Hornet 14, which is usually my choice wire in these types of scenarios. It's tapered, it's got high tip strength, it's able to enter through fibrotic tissue reasonably easily with a microcatheter backup. And we puncture right into the structure of the vessel. Great, this is CTO PCI, right? Dissections don't scare us. We're in the structure of the vessel. This case is moving forward. So the nice thing about using the IVUS now is we can in fact confirm without using antegrade injections or without using even selective retrograde injections that we are in the structure of the vessel, because you see the wire here at about 3 o'clock, that bright spot inside the CTO segment. Then we try to deliver a stingray, which you can see here. That's a focused reentry device for antegrade dissection reentry that we're all familiar with. We perform a successful stingray ADR reentry, and this was done as a stick and drive. A true lumen wire position was obtained. Once again, we were able to use the IVUS to confirm the presence of a true lumen wire that then goes into the plaque a little bit further back. And we'll just slide this back forward, okay? And then we perform PCI and get a very nice result. Are we done? Well, this is now the traditional use of IVUS, where we see that the distal edge of this stent is really nicely sized, but as you come back within the vessel, you've got fairly gross undersizing of the stent. And that's not surprising because this is a large circumflex. And this is where we make the difference between getting acceptable outcomes when we walk away from a case to optimal outcomes when we walk away from a case. We have gross stent under expansion here, and so the IVUS then allows us to really optimize the stent sizing for this particular case to get an excellent final result. So here, IVUS lent clarity to ambiguity in terms of where we put our wires in CTO PCI. It facilitated looking behind the proximal cap. It's a little different than the traditional use of IVUS that we have in the evidence, but this is where IVUS and CTO PCI can become particularly useful. Another case is optimizing crossing, which is IVUS-guided reverse dissection reentry. So fundamentals of reverse dissection reentry, and again, for our audience, I won't belabor this too much, but you put a wire into the antegrade subintimal space, you come retrograde through your collaterals, and you put a wire into the retrograde subintimal space, and you put a balloon on this antegrade wire to create a common space where the retrograde wire is then advanced into the antegrade guide catheter. In cross-section, this is what this looks like, where this is your occlusion. This is your antegrade wire in the subintimal space. This is your retrograde wire in the subintimal space. A balloon comes here to tear these tissues so that this wire can go near this wire. Simple, right? Well, not always simple. There are many reasons for difficult reverse cart. There are many reasons why it's difficult to make that connection. Reverse cart was not performed in the optimal location. And that's defined as the place where the wires are closest together. There's a lot of vessel tortuosity, so you don't know whether one wire is pointed in one direction, one wire is pointed in another direction. With this kind of tortuosity, it can make it almost impossible to create a common space. There's severe calcification. As we've discussed, calcification is very difficult to manage, and creating common tissue planes when vessels are particularly calcified can be quite challenging, especially when you don't know where your wires are or where the wires are closest together. The balloon dilation isn't performed all the way back to the true lumen proximally. The knuckles have caused big hematoma, so you have bad subintimal space management. And your antegrade or your retrograde wires are in fact not in the same plane. They're not both in the subintimal space. These are things that are going to require more than just careful looking on fluoroscopy, or worse, antegrade injections of contrast, because of course with antegrade injections in CTO PCI we can advance dissection planes. And so this is one place where IVUS can become quite useful. So this is a case that we did a while ago where you've got a right coronary chronic total occlusion, you've got nice retrograde collaterals coming up, you've got a fairly long area of diffuse disease culminating in a proximal chronic total occlusion. So here we define the nature of the CTO reasonably well. There's obviously this big dominant collateral that was defining the RCA. We decided to use septals, and we were able to cross easily from the septals into the main body of the RCA. We then managed to get an antegrade wire going into the RCA. It was quite stiff. There was a lot of calcium. There was a retrograde Carlino that was done to help loosen up some of the tissue, but we were ultimately able to successfully knuckle a wire into the RCA. So now you've got a retrograde wire and an antegrade wire. They're certainly both in the same tissue architecture, but do we know that they're actually in the same planes? Well, we attempted reverse cart and we failed. I remember learning from Dimitri many years ago at Columbia, where he said the 5 reasons for failing reverse cart: your balloon is too small, your vessel is bigger than your balloon, there is not enough balloon for your vessel, your chicken, you need to take a bigger balloon, right? And then it was him that taught me many of these excellent strategies to be able to understand how we can use IVUS to really optimize these scenarios. So in this case, when we IVUSed, we identified that here's one wire here, and here's another wire here. There's our antegrade wire, there's our retrograde wire, but we were in a huge area of the subintimal space. This area was grossly expanded by the retrograde Carlino that we had performed, where our subintimal space was a particularly difficult space to make a connection because it was so big. So instead, we moved our base of operations to right here, where the subintimal space wasn't nearly as large. And as a result, we performed ballooning on the antegrade wire, not in this space where it was very, very large and we were having difficulties creating the same plane. And believe it or not, even though these wires look like they're close together, there are actually separations. But a little bit further down, right here, where the wires are slightly further apart, but we understand that they're both in plaque. That allowed us ultimately to perform our reverse cart right about here, find ourselves in the antegrade guide, and then perform PCI to achieve this final result. You can see the big hematoma here in the dissection plane that we identified on that IVUS. We were able to just post-dilate this a little bit further to get a very nice final result. So the key here with IVUS is it optimizes your crossing by helping you identify when both your antegrade and your retrograde limbs are optimally placed to make a connection, not in a huge subintimal space, but reasonably close to each other in a plaque segment, or in the subintimal spaces on both sides, but without a huge hematoma. This is another one called Don't Get Lost. So this is identifying your crossing path and your distal landing zone management. So this was a case where we did a multi-vessel PCI with CTO, and here are our dual injections. And you can see the chronic total occlusion proximally here. We were able to cross this fairly easily with a standard wire and then performed PCI. But then despite putting huge stents in, we have this worthless looking outflow, this tiny little vessel, and I was very unhappy with this. So recognizing that there must have been a lot more RCA here and seeing all of this calcium, we put in a second catheter, and now we realize that this is in fact a fairly large dominant RCA, but that the entire RPL system is missing. So now how do we go about getting this? Because this is now stented over and it is very, very smooth, right? So it's very difficult to identify where this connection takes place. And here we can use IVUS in a couple of different ways. We identified the proximal cap with IVUS, and then we're able to use it to enter the occlusion segment, same way we did in the first case. But now we take a hydrophilic wire, and hey, sometimes it's better to be lucky than good, right? So we have a Fielder XT in this situation that was knuckled, and boom, you see it pop very, very nicely into the true lumen. The problem is there's a whole bunch of branches back here. So do we now just balloon this and leave it to heal, or can we stent this, recognizing that we need to make sure our entry into the true lumen in this branch happened before the other branches in the RPL system? And this is just proof that we're true lumen here when we look at the retrograde entry, but I don't know whether or not this is subintimal here. The wire is subintimal here. So if I stent from back here to here, I'm going to shut this whole section down. There are data in JACCI just this year showing that when you lose side branches of any significant importance, the outcomes are abysmal with CTO PCI. And so this is actually a particularly germane piece. You need a very deliverable, relatively thin IVUS with high definition capability to identify these things, which is why, you know, some of the rotational IVUSs, particularly the 5 French Opticross by Boston or the 6 French HD, are particularly good IVUSs for this purpose. So you can see that, unfortunately, this is not playing as well as I would like, but you can see that where we started, we're in the true lumen. But then as we come back, this is where the false lumen begins. Now, as we look on the IVUS, coming back here where we started, and slowly coming back, you'll see that there's the branch. There's the branch coming off right here, and that's still true lumen, okay? But then as we come back, we see your subintimal space starts to come in right here, right? Where your true lumen now is here, and you're in the subintimal space here, right? So SI true lumen. But remember that the entry into the true lumen was before the branch came off, which we just proved with the IVUS. And so then as we come back on the IVUS, we can identify here now, we're back in the occlusion segment, and this is true lumen again. You co-register this on the fluoroscopy so you understand exactly where you are. You know exactly where to land your stents and balloon. This is coming back into the RCA. And ultimately, we were successful despite that in achieving this final result where every branch was preserved and where we had good outflow now into the true dominant RCA that we wanted. And as you can see, there's an impella in this patient because the EF was very low. So these are the types of individuals who really need every branch open if you can get them. And then for one more case to show you, this one's called optimizing your results. Make sure your investment pays off, right? And this one I found, I mean, when I saw this as the operator, I was shocked at what I saw, and it taught me a lot about CTO PCI in general. But this was a CTO PCI in a 63-year-old guy with chronic kidney disease. Severe kidney disease, lots and lots of calcium, not an overly long CTO, looks like something that, you know, we should be able to get, right? The good septals coming into the distal RCA. There's filling all the way up into the proximal vessel. There's a bunch of bridging collaterals here, but it looks, it looks doable. Unfortunately, we failed for a variety of reasons and decided that we would have to invest. So investment procedures we've identified through the data work pretty well, right? There's good TIMI3 flow now. There was a tight lesion up here proximally. We ballooned that. We used subintimal plaque modification to achieve a bunch of branches distally, and you can see a very nice blush here, right? So we've got a reasonable investment result. The key is don't stent this, and let's bring him back in 6 to 8 weeks and see how he's doing. So we bring him back, and symptomatically he's improved, but by what we see, we end up being rather shocked. Now, where the proximal cap was, there's a very critical tight lesion, but look at how many branches there are. 1 branch, 2, 3, 4 big branches. The problem is you can see multiple dissection planes in the mid-RCA. Remember how we left this investment result. We only had 2 decent sized branches when the investment finished, right? There was this one and this one. There were these tiny little branches. So now you've come back and the number of your branches has increased by over 50%. 1, 2, 3, 4. The challenge is, I don't know which lumen is giving rise to which branch because there are about 5 dissection planes in the middle of the vessel. So he's improved, he's got more branches, but the critical lesion in the proximal right coronary artery is causing problems. And there's now an impetus to fix this. So when we do the angiogram, one of the things that we recognize on the angiogram is that in fact, there is flow antegrade in the true lumen here that then becomes the subintimal space, and that the flow is in fact, the flow is in fact going back up the true lumen on this side of the vessel, right? So if we can let this play for a moment and pause it at the relevant segment right here, you can see that flow is coming down antegrade, but then actually this is all false and then goes back up the true lumen here and then starts to fill true lumen down here and starts to fill false lumen down here. So great. How do we stent this? Recognizing that on IVUS, we've got a big subintimal space where our wire went very, very easily because this is now matured and healed quite nicely. But with this true lumen space on the side giving rise to another 1 or maybe 2 branches, do we just leave it alone? Well, remember, he has symptoms again. He had a proximal RCA lesion that had recurred too. Do we pick a branch? Well, we know that losing side branches is not good in CTO PCI. Do we just do a full metal jacket of the RCA and hopefully they all stay open? You know, as you've heard Bill Lombardi speak many times, I'm sure hope is not a strategy. We've got to identify and understand the vessel. So the problem here in this guy is that he has an important RCA lesion at the proximal vessel, right? And that's what's limiting flow to all of these branches. But there's all kinds of plaque here as well. And so figuring out where to land your stent becomes an exercise in identifying where the connections are between these various false lumens to try to identify where to stent. This is what it looks like when he comes back, right? So you've got this, I'll rewind the IVUS here. You've got this IVUS plane. So you've got big false lumen here. You've got the true lumen on this side. Then you kind of go back and now you've got a little bit of false with some open dissection planes here. Then you're coming back into a confluence of true versus false. And now you're coming back into true. And so what you can see is that there are various different connections coming off of this sort of confluence point. So what needs to happen is a careful co-registration on fluoroscopy of this confluence point where you've got 1 lumen here, 1 lumen here, you know, one lumen here, 1 lumen here, where these are all giving rise to different places or different branch points so that you know exactly where to land your stent. As you can see, the vessel itself is actually very, very large. This is an important dominant right coronary artery for this gentleman, but picking 1 lumen over the others is not optimal. And the only way you really understand where this confluence point is by using intravascular ultrasound. You can't do this on angiography, especially because you're going to advance dissection planes. This was that different directional flow. Sizing we talked about, it's a huge vessel, 4.51 millimeters. So ultimately, we identified where to land this stent. This was the confluence that we had observed. It was just below this. We knew that his critical lesion was up here in the proximal. So we put a 4.0 millimeter synergy stent in, post-dilated it with a 4.0 to 22 atmospheres, and this was our final result with the proximal RCA lesion treated and post-dilated, and with a 1, 2, 3, 4, 5, all of the branches preserved. This guy 1 year later is totally asymptomatic and feels great. So that's another way to identify not only the tracks where your investment has resulted, but to make sure that your investment pays off. This is now not facilitating crossing, but facilitating an understanding of the anatomy, so that it going beyond just usual stent sizing, we understand where to put our stents and how to preserve our branches in CTO PCI. Do I have time to present one more case, or are we sort of over time now?
No, Shangyog, I think we are over the time, so we
All right.
go for discussion. And
I'll stop there.
we have a very learned faculty with us. Dr. P.K. Goel, are you with us? Dr. Rajesh? Dr. Sanjay?
Thanks
Dr.
very much for your
Deepam-
time and attention.
Any comments? Any comments? He has shown some beautiful cases. Thank you very much, Shangyog, for a beautiful lecture and showing excellent cases, superb cases, and you followed it up so nicely and ultimately had so wonderful results.
Thank you, Dr.
Thank you
Sanjog.
very much for your great lecture. So I invite questions from our learned faculty.
Instead of IVUS, if you would have used OCT, would the approach have been different?
So I think I get very nervous with OCT in these large dissection plane ridden arteries, because when you're flushing contrast forward at such a rate, or even saline now with saline OCT, you know, we've all seen distal vessels shut down because of expansion of subintimal spaces. So I think you could arguably use an OCT and co-register with IVUS guided proximal cap puncture. But then once you're into the proximal cap, if you've got any segment of subintimal space before you do your reentry, you're going to then end up potentially advancing dissection planes when you want to re-image to confirm your placement. In retrograde dissection reentry, as you could see, the problem was that there was a huge subintimal space, and so flushing forward once again may expand that. And that's why IVUS was a preferred technology in this sort of
I was
scenario.
talking about the last case. Would it help to identify the true lumen in then stent tip, because there were multiple dissection planes in that case?
Correct.
So
Correct. And that's actually exactly what we did. Yes. So we identified that it was all true lumen proximally.
Yes.
And then we identified the connection point, which was almost like a neo-polygon of confluence, where you had multiple dissection planes giving rise to multiple true lumen endings.
Yes.
And what we did was identified where the true lumen ended in the mid vessel and stented all the way back to the proximal vessel. So the true lumen was all stented, and all of the multiple lumens distal to them were getting TIMI3 flow and remained open. And we see that, of course, in investment results a lot of the time with CTO PCI, where the patients don't come back because they have such a nice investment result. They've got TIMI3 flow into the true lumen distally, and they're fine.
Dr. Gary Means, any comments?
Well, I think Sanjay did a really nice job. And there are just so many ways that you can use IVUS in CTOs. But as I will show you in my talk, there is one randomized trial where IVUS guided CTO intervention has a 75% improvement in event rate at 1 year follow-up. And it's actually the largest impact of IVUS guidance is in that particular trial.
Yeah, we did a study at Columbia, as you know, Gary, a couple of years ago, right, where we systematically, this was before IVUS CTO, but oh no, this was after IVUS CTO, I think, while it was going on and just after the primary results had been presented. But we had a series of, you know, a couple hundred odd CTOs where we systematically IVUSed all of them. And we found that, you know, almost a quarter of the time when you think you're going true to true, in quotes, you're actually true, false, true.
Yeah.
And that the more you spend more time in the false lumen, the more complex the cases became. So the more you do CTO PCI, I think your relative benefit of IVUS, not only from an outcomes perspective, but from a technical success perspective, goes up. And the more difficult the cases you are with the more experience you have, the better your reuse of IVUS becomes.
Well, and you know, our Japanese colleagues do IVUS in 100% of their CTOs.
Mm-hmm. Absolutely.
Rajesh,
Yeah,
any
it's interesting. I
comments
mean, go ahead. Sorry.
Continue, please. Yeah.
No, I was saying, I mean, I was in the United States, as you know, but I'm now in Canada, where we are in a managed healthcare environment as well. And so the impetus behind using technology is data, right? Or I should say our data. You have to have good justification. It's not a patient pay system like it is in India, but it's a society pay system. And so everything that we do must have reasonable evidence or have really reasonably good clinical rationale. And despite being in that type of a system where IVUS catheters are expensive and not funded here, our institutions recognize the importance of this technology and are pushing to make sure that it is very available to operators, because we realize that you know, a Jackie Shroff film comes to mind, right? Where they say that the more you sweat in peace, the less you bleed in war, right? You know, and I'm sure many of you will recognize the film, right? So the more you spend the time to understand the vessel where you're stenting, the better your results are when you leave it the first time, the less likely you are to have to come back and fight a war. I think the data show that pretty clearly.
From our faculty? Any comments from faculty? Dr. Sanjay Tyagi, Dr. Hiramak, Dr. Rajesh Vijayavargi, Dr. Baal, Dr. Dipankar Mukherjee. Any comments?
I think they were excellent cases and showed good use of IVUS catheter to identify in such difficult situations to bail out the situation.
Thank you.
So thank you very much, Dr. Sangjok Kalra, for your beautiful lecture and beautiful demonstration of very difficult cases under practical scenario. So thank you very much. And I would also request you to be with us, if possible, to chair the future session. We have 3 more sessions, and I would invite no other than Dr. Gary Minch to kindly deliver his lecture on IVUS in chief case decision making. So Dr. Gary Minch, please.
Some reason. Give me 1 second. So thank you very much for inviting me to participate. And I am going to share with you some data and some cases about the use of IVUS in chip case decision making. This is Ajay Kurtanay's classic article in Circulation. I am obviously not going to be able to cover all of it, but I will hopefully go through some interesting lesion subsets. Let's start with left main lesions. These are 2 excellent review articles if you want to learn more about IVUS guided left main intervention. But in terms of deciding whether or not to treat a left main lesion, there is data both with FFR and with IVUS, and this excellent meta-analysis shows that they're really roughly equivalent in selecting the lesions or identifying the lesions that should be revascularized. Let me share with you one IVUS case. This is a patient who was on the cath lab table for correction of anomalous pulmonary venous return. He was an adult male, so he had a coronary angiography performed. And I would ask you whether you think this osteal left main lesion is or is not significant. But based on the IVUS pullback, there's almost nothing there. This is a totally normal osteal left main. And notice that in order to visualize it properly, the guiding catheter must be disengaged. Now, in about 25% of patients, the MLA differs by about 1 square millimeters when imaged from the LAD or the circumflex. So it is really important when doing left main intervention to do IVUS pullbacks from both the LAD and the circumflex. Here's a clinical example. Here's the angiogram. This is probably a 110 Medina classification. By the circumflex and LAD pullback, here's the left main from the LAD pullback. Here's left main from the circumflex pullback. And notice that it's much smaller. And this is the correct MLA. This is the result of angulation. It's also impossible to assess the circumflex from the LAD pullback or vice versa, and they don't have anything to do with Medina classification. So this is a paper we published more than 10 years ago, and you can see that irrespective of the Medina classification, 60% of distal left main lesions involve the LAD and the circumflex, 14% involve the LAD with focal disease of the circumflex, and 14% involve the LAD with no disease at the circumflex. And back to our clinical example, you can see that there's a lot of disease at the ostium and the circumflex that is not seen on the LAD pullback with tangential view of the circumflex. Here's another example, LAD CTO, but you can see that there's involvement of the distal left main as well. So when you do the pullbacks on both the LAD and the circumflex, you can look at the circumflex IVUS and decide whether or not you should start with a 2-stent strategy. This is data from Sujin Kang from Asan Medical Center in Seoul, Korea. And if the lumen area in the circumflex is less than 4 and the plaque burden is more than 50%, you have a pretty good chance of jailing the circumflex and having an FFR less than 0.8. And recent data from Bangkon Ku's group, also in Seoul, you can see that if the FFR is less than 0.8, there's a 3-fold increase rate of events at 5 years of follow-up compared to an FFR more than 0.8 after 1 stent crossover. Also from Sujin Kang, we have criteria for stent optimization in the left main, LAD, and circumflex. Her rule of 5, 6, and 8. And if you have underexpansion of any one of these areas, you have more events at follow-up. But from the Excel trial, at least in Western patients who have bigger arteries and bigger hearts, those numbers are probably too small. And we're probably talking about 9 in the left main, 7 in the LAD, and again, 5 in the circumflex. Also from the Excel trial, the importance of acute stent deformation. If you have acute stent deformation, your event rate doubles. And this is a clinical example, distal left main lesion, post-LAD left main stenting. And you can see that the stent was underexpanded. It was then post-dilated some more. And even though the stent is now better expanded, look what happened here. Single layer of stents, multiple layers of stents. The stent area in the left main has decreased, and we now have clear evidence of stent deformation. What I'd like to do is share with you a case from China, a 60-year-old male, a female with chest pain and dyspnea, becoming worse for the past 4 months. Here is the ECG, which is not terribly remarkable. And here are 2 angiographic views. Obvious severe distal left main lesion. And then other views, something that looks like a filling defect in the distal left main. Well, the patient was treated with multiple drugs in an attempt to reduce what was thought to be a thrombus, including 2B3 inhibitors and low molecular weight heparin. The patient was brought back to the cath lab 5 days later. No real improvement in the angiogram, and thrombus aspiration yielded no thrombus. So then they did IVUS, first from the LAD and then from the circumflex. And let me just show you the LAD pullback first. You can see a lot of calcification. And as we get toward the ostium of the LAD, a huge calcified nodule. And if the pullback from the circumflex, similarly, a huge calcified nodule at the ostium of the circumflex. So what we have is a calcified nodule involving the distal left main bifurcation, the ostium of the LAD, and the ostium of the circumflex. Here are some still frames to highlight it. And the patient had stent implantation with a DK, with a crush technique, and an okay but not great result. In terms of data, there are now 4 meta-analyses looking at the studies comparing angiographic versus IVUS-guided stenting in left main disease, and you can see a reduction in cardiovascular mortality of at least 50% in each of these meta-analyses. The most recent meta-analysis shows a reduction in all-cause mortality by 40%, cardiac mortality by 60%, and stent thrombosis MI and TLR as well. And this is the largest randomized trial in China, a reduction in cardiac mortality from 6% to 2%. And this is from BSIS, which is a national registry in the UK of over 11,000 left main PCI, half of them imaging guided, half of them angio guided, showing a nationwide 34% reduction in 1-year mortality with IVUS guided left main stenting. Calcification, as you've seen in previous cases, is a real problem. I wrote this paper almost 30 years ago, highlighting the limitations of angiography in assessing calcification. And we now have a paper that hopefully will be in press in Circ Intervention with a IVUS calcium score predicting stent under expansion based upon a length of calcium of at least 270 degrees, a calcium nodule, a small vessel diameter, and the presence of fully circumferential calcium. And if you have a score of at least 2, you are reliable. You can almost guarantee that your stents will be under expanded. So here's a clinical case, 45-year-old male with type 1 diabetes and chronic renal failure on hemodialysis. This is his right coronary with a calcified nodule in his right. Notice the calcified nodule, long length of calcium, and circumferential calcium. His score is 3. And after stent implantation with the highest pressure balloons that we have in the US, stent expansion was only 45%. Two months later, the patient is back with in-stent restenosis. You see that the calcified nodule is now back inside the lumen. It has probably fractured the stent. Another PCI was performed with a drug-coated balloon. This was done in Japan. Not a bad angiographic result. Another 2 months later, it's back again, and this time looks worse. They placed another stent. And another 1 month later, it's back again. Calcified nodules are bad news, and we don't have a good way to handle them. And this is the data that supports it. This is a study from Japan with rotational atherectomy of heavily calcified lesions, showing that calcified nodules have a doubling event rate, if not more, compared to heavily calcification without a calcified nodule. And this interesting also study from Japan shows that the mechanism of in-stent restenosis is that the calcified nodule fractures the stent and prolapses back into the lumen. You just heard a superb talk on CTOs. This is a nice review article if you want more detail, but let me share with you a few cases. This is a ostial LAD CTO. The IVUS catheter is parked in the small side branch and pulled back from the ramus to the left main. Here identifies nicely the ostium of the LAD. It's not only identifying the ostium of the LAD circumferentially, the average difference between where you think the ostium is longitudinally and where it actually is anatomically is about 5 millimeters. This is a case similar to another one that you saw of a reverse cart. You can see the guide wire in the medial space, the retrograde guide wire. Here's the antegrade guide wire, aggressive post-dilation. Now they're both in the true lumen, but notice the amount of intra and perivascular damage. This represents a perivascular hematoma, or if another word of saying this is a subtle perforation. But you often have to do this amount of trauma to connect the two wires, as you can see here. This is another CTO in the right. Here's the angiographic result. You see some contrast extravasation. The distal right, the iris is in the true lumen. The proximal right, the iris is in the true lumen. But in the middle, you see that the iris is in the false lumen with a break in the vessel wall as well. And this is another case of a CTO, in-stent CTO in the right coronary. And if we go antegrade, we're in the true lumen antegrade. True lumen antegrade. Now we've left the stent. The stent is here. The stent is here. We're in the false lumen, and we're the false lumen all the way down into where the guide wire was, which was not the true right coronary, but an acute marginal branch. As I mentioned, IVUS guided CTO intervention probably has the greatest impact on outcomes. Out to 1 year follow-up, 75% improvement based upon intention to treat, 80% improvement based upon per protocol. Myocardial infarction, there's now data from the CAMIR registry in Korea. This is an online registry of STEMI patients showing that IVUS guidance reduces patient and device-oriented cardiac events based upon a reduction in all-cause mortality and cardiac mortality. And you've heard a lot about renal insufficiency. The prevalence of contrast-induced nephropathy increases with baseline renal function and the amount of contrast that is used, and is paralleled by an increase in mortality. If a patient presents with chronic kidney disease and develops contrast mortality, the mortality at 1 year, contrast-induced nephropathy, the mortality at 1 year is 25%. And Ziad Ali in our group pioneered zero contrast PCI. If you do zero contrast PCI with contrast sparing angiography, you have no impact on the need for renal replacement therapy at 1 year of follow-up. Lastly, in-stent restenosis. These are 3 cases of in-stent restenosis, LAD right and vein graft. Here it is in the LAD. The cause is chronic stent under expansion. Here in the right, the cause is crushing of the stent against the vessel wall. The operator lost wire position, and when recrossing, went into the stent, outside the stent, back inside the stent, and when post-dilating, crushed the stent. And here it is at the ostium of the vein graft. The operator left a lot of stent hanging out in the aorta, and when withdrawing the guiding catheter, he pulled the stent out, so that this really isn't in-stent restenosis. It's just recoil of an unstented ostial vein graft. And there's now data from the Washington Hospital Center that IVUS-guided in-stent restenosis intervention improves patient events at 1 year follow-up. A little bit more about data. This is a registry from Korea showing that IVUS-guided complex patients and lesions reduce mortality at 10 years of follow-up, irrespective of the lesion population. And this is true in second-generation stents as well as first-generation stents. In fact, it's even more true with second-generation stents, with a reduction in mortality of 67% compared to 36%. And in complex patients, a reduction in mortality that averages about 50%. Why? Why does intravascular imaging reduce mortality? Because stent thrombosis and restenosis are not benign events. These are the mortality associated with the development of stent thrombosis and its treatment, and DS restenosis and its treatment. And you can see that the mortality is not trivial. Out to 5 years, it can be 5%. We also do a bad job teaching about intravascular imaging. This is a survey we did of cardiology fellows attending our fellows course, and you can see that a minority are properly trained in physiology, IVUS, and OCT. Education is expensive, but to quote Benjamin Franklin, who is one of the founders of the United States, or Barack Obama, who was a president a few years ago, if you think education is expensive, wait until you see how much ignorance costs. Thank you for your attention.
Thank you, Professor Gary Minch, for your magnificent lecture. You not only gave a very good lecture, but also you have shown us that how different the cases may be and how IVUS helps. Also, thank you very much for showing the Korean data that IVUS reduces mortality from 17% to 10.2% on that part. So thank you very, very much. Now the session is open. And without wasting any time, we have Dr. P.K. Goel with us and Dr. Rakesh Jadhav and Dr. Dilip Kumar. So all are doing many cases of cheap lesions. So your short comments, please. Dr. Goel first. Make yourself unmuted. Dr. Goel, you are not audible.
Great. Okay, that's fine. I think it was a fantastic lecture, I would agree. And IVUS today has certainly increasing role in interventions. And the mortality outcomes and the patient clinical outcomes that follow up are certainly better if you do IVUS guided procedures. This is what I have observed. And left main cases, I think he showed a few examples. In fact, if you ask me, well, I probably do imaging guided left main interventions in more than 80% of the cases. And the other thing which I would like to ask Dr. Gary Minch, if it's the time permits, what is your thought on the size that because by IVUS, what we get is the true size of the vessel. So we can put bigger size stents and stuff. And so we get better results. This is also one of the reasons why we get better results. So what is your take on the size of a vessel that you see on the angiogram versus the size that you see on IVUS? So do you think there is a correlation? Because we did work out a correlation. So what is your thought on that? Because
well, I mean, there's certainly a correlation. The question is, what is the average difference? And the average difference is between 0.5 and 1 millimeter. And the percentage difference, is greatest in smaller vessels.
Is more in the smaller vessels.
The percentage difference, not the absolute difference.
Yes. Actually, we just worked out a study on left main cases where we had the left main, the osteoproximal LAD, and the osteoproximal circumflex measured in those cases where angiography can show us reasonable sizing to be done on angiogram, and then correlated it with the IVUS pictures. And there was a correlation that came, which was nearly a straight line in an equation y is equal to mx plus c. That is the true size is y, which is the IVUS size, is about 0.75 plus 1.05x. You know, in the sense you multiply the angiographic size by 1.05 times and then add 0.75. The similar analogy as you were saying, in smaller vessels, you will add more. In bigger vessels, you will add less relatively. So something like that. We did it in a few. Yeah, please.
So proximal LADs are never 3 millimeters.
They're more than that.
They're more than that.
Yes.
Left mains are never 3.5 millimeters.
Correct. So that is what that is correct. So that is what I would, I'm just saying the same thing.
No,
so people putting 2.5 or 2.75 stents in proximal or osteal LADs are always undersizing them. And that's what is not correct. And that's where IVUS helps. But if you understand this logic, then probably you could even do it without IVUS if you.
Well, I mean, but when you look at the mortality data with left main, which is driven primarily by the minimal stent area, which is not 100% predictable by the angiogram, no matter what it looks like. The entire UK had a 34% reduction in mortality with left main intervention. And the interventionalists who had the greatest increase in patient survival were the ones who did the most left main procedures. I mean, that's this is a national study. It's not 100 patients here, 100 patients there. This is a national mortality outcomes, National Heart Service registry study.
Yes, so probably the experience counts, and the size that you put into the left mains and proximal LADs, that also counts.
Yeah. So Dr. Rakesh Yadav there, Dr. Dilip Kumar, Dr. Rajesh Vijayvargi.
So Dr. Minj, very nice presentation. I just want to add some clarification on the 2 points. One, as you mentioned about, say, angiographic versus IVS correlation and the mathematical figure of, say, 1 or 1.5 millimeter difference between the two. Your first case has a marked difference between angiographically left main disease versus IVS, which didn't show any disease at all in the left main. So how do you explain this one? And the second comment about your, say, importance of calcium depth, which is there in the OCT and of course not there in the IVAS. Is it going to have a technical and clinical outcome effect during the PCI of a calcified lesion?
Yeah, so the left main is the coronary segment that's least reliably assessed angiographically. And within the left main, the ostium, the orosteal junction, is the location that's least reliably assessed. These are angiographic artifacts caused often by the angiographic catheter. I have a whole series of osteal left main lesions just like this. In fact, I have an old case before we used to stent these of a patient who had bypass surgery for an osteal left main lesion. The grafts closed. They operated him a second time. The grafts closed a second time, and he had no left main disease whatsoever. It was an angiographic artifact. If you see an osteal left main lesion, you should be very suspicious that it's not real, period. Now, in terms of calcium thickness, obviously IVUS can't do calcium thickness, OCT can, so the calcium scores have to be different. The OCT calcium score factors in calcium thickness, at least 0.5 millimeter has a major impact. Because we can't do calcium thickness with IVUS, we have to use other parameters. And that's why our model includes totally circumferential calcium, 360 without a break, length, much longer than by OCT, calcified nodule, and small vessels. And in some ways, small vessels becomes a bit of a surrogate for calcium thickness, because if the lumen is smaller, then you have more room for calcium and therefore can be thicker. But the models have to be different.
Very nice. Thank you. Excellent.
Dr. Gary Minj. Yeah. Dr. Devabrata Roy, any comments? Dr. Roy? Anyhow, so thank you, Professor Gary Minj, again for your magnificent lecture. We enjoyed and learned a lot from your lecture as usual. And let us hope that next time we meet in person. Last time you came a few months back in Kolkata, just before the lockdown. And we remember. Thank you very, very much, sir. And I would like that if you kindly stay with us, I would request you to be with us. So I would invite.
If I may say one thing, sir, my last trip before the pandemic was to India 1 year ago, and I enjoyed myself very, very, very much. And I hope to be able to do it again soon. Unfortunately, I have another appointment in 15 minutes, so I will not be able to stay with you. I'm sorry.
Okay, sir. Thank you very much on behalf of NIC CSI, and I would be hoping that you will be available next time also. Thank you very, very much, sir, for your great lecture. So next I'll be inviting Dr. Ramesh Dagubati, who is a very close friend of ours and of NIC CSI, and always comes whenever invited and can deliver lecture with a very small notice. He would be talking on a very interesting subject, best practices for treating high-risk patient subset, lessons from SKY position statement. So it's a very important subject, and I would invite Dr. Ramesh Dagubati. He was very busy till some time back in the lab with a very critical case. So Dr. Ramesh, are you there?
Dr. Kahali, I'm here, but unfortunately, I'm not able to start my video, but I still am audible and I can go ahead and give the talk. Is that all right?
Okay. Okay, that's all right. Though will
Yeah,
be missing the video, but what can Raghu, can you help Ramesh in getting it done? Raghu? Are you there? Raghu is our tech expert, so he's very good.
So Dr. Kahali, I think it has nothing to do with it's my side.
Okay.
I think unfortunately, maybe I can go ahead and talk. I mean, most of my friends have seen my face. I think it's really great to be part of this NIC CSI program, and if it is okay, I'll proceed. If not, I can try to reboot my
please
computer.
Proceed. You please proceed. You please proceed.
It's a great pleasure. Actually, thank you, Dr. Kahali, for giving me this opportunity. And as I'm in between some TAVR patients that I might have to leave after the talk, but I'll do my best to produce this talk that has been allotted to me. So good evening, my friends. SKY position statement on best practices in high-risk lesion subsets is my talk today. This paper has come out from Robert Riley and Farouk Jaffer and all our other colleagues of mine who are in the SKY board members as well and in the publication committees, as you know. So the objective of this paper has been to go back and look at the state-of-the-art clinical evidence that we have and give procedural guidance to optimize outcomes for all the physicians that are practicing. So first of all, let's start off with the pre-procedural assessment. There are several scoring systems. Start off with the STS score, whether the patient should go for bypass surgery or not, to Roxana Mehran's contrast-induced nephropathy score, Euro score, and the syntax scoring, as well as multiple scores, as you know, for high bleeding risk and everything. So this is a statement that actually just shines light on how probably you can assess the patient's risk and actually be more neutral in discussing with the patient's benefits and risks and alternatives for that patient. So what we do in our cath lab is always we have a syntax score, as well as we also look at the TAVR risk mortality versus STS risk mortality for that patient, and look at everything in conjunction. And then we bring a patient back to a conference where a heart team is the surgeons, cardiologists, cardiac heart failure specialists, everybody is there, and we discuss about that particular patient. So heart team discussion is very important, and we document that as well. And complete the revascularization is also very important for achieving the optimal results in these patients. And knowing whether we can do that is important. And how do we tackle with surgical turndowns or high-risk surgical patients? That's sometimes we come across these patients. And then acute coronary syndromes of STEMI patients and people with the impaired LV function and cardiogenic shock, renal insufficiency, diabetes, and concomitant valvular heart disease is also really great to deal with, how to know. So this is a paper from Patrick Serres, and he actually looked at the XL patients who left main. And then by simulation, they created a 4-year mortality on syntax 2 scoring system. So if you see this paper, you look at it and there are several subsets of whether the patient has COPD, diabetes, age less than 65, more than 65, and all of them. You can see that actually by doing this type of risk scoring system, you can say that a patient who would be favored bypass surgery are only less than 5%, even if the syntax score is more than 22 and up to 32 for left main in Excel studies. But people who favor PCI are about 11 to 40% depending upon the syntax score. But so majority of them are neutral. So this is where we come to an equipoise and say that CABG may be as effective as PCI or vice versa. Okay. So the SKY actually come up with a shock statement as well as a complex PCI comorbidity statement and risk classification of these as well, looking at people who are ambulatory to inpatients and hospital patients. So people who could actually come as an ambulatory and nowadays in the United States, the government has approved same PCI can be performed in ambulatory PCI centers, which are cath labs that are outpatient based and don't have to be attached to a hospital or even with cardiac surgery. So say stable coronary artery disease without complexity, those patients could have actually ambulatory surgical center or hospitals. They can be undergoing PCI in these centers. Has this practice taken off? Not yet, because even though the government, Medicare has passed on saying that we will pay, several states are not up to the standards yet, and they are really looking at it very carefully to see whether we can perform these PCI in stable coronary artery disease patients at ambulatory surgical centers. But otherwise, complex comorbidities, complex PCI, or those patients we'll talk about with the EF less than 13, New York Heart Association class 3 to 4, chronic kidney disease, severe anemia, contrast allergy, severe peripheral vascular disease or aortic stenosis, and patients who have coagulopathy, pulmonary hypertension, lung disease, or by anatomical criteria, left main, bifurcations, all of them actually are chronic total occlusions. They have to be performed in a hospital. Okay. Whereas in the AE classification is the people who are in a cardiogenic shock or cardiac arrest, they of course have to be performed only in a hospital and not as an outpatient, they are inpatients. So some places actually complexity, can it be done as an ambulatory, meaning they are not done at outpatient cath labs, but in a hospital, but they come from a home and go back home on the same day. That's a possibility. All this depends upon how you score the patient and get a complex PCI based on their anatomy, the comorbidities that they have, as we discussed, and the equipment that we are going to use. Such as atherectomy, and do you have covered stents available, and FFR and OCT as our imaging, intravascular imaging, as we talked about. And going to the other extreme, people who need a ventricular support are the ones that probably they might need a right-sided support in acute coronary syndrome, cardiogenic shock, or people with some aortic stenosis might also initially have an impeller placed before, or a tandem heart that is placed before intervening on those particular left main or LAD bifurcation type of vessels. So there you have to have knowledge about using all these devices, the balloon pump to impeller to tandem heart as well, and ECMO. So then let's start off from the small things, which is actually radial versus femoral, heparin versus bivalvular. And this debate, I think, in my opinion, has been settled, but some people probably still argue one versus the other. As you can see, the axis radial has been shown to have much better net adverse clinical events as compared to femoral. So the number needed to actually treat is about 50 patients of by radial to actually have one patient prevent having bleeding or other length of stay hospitalizations. So SKY actually promotes radial because the entry site complications and length of hospital stay is much lower in radial compared to femoral. But then came out another study called Safari STEMI. It looked at the primary outcome and 30-day mortality in STEMI patients. So I think one of the things that you can see, radial versus femoral, and you might say femoral is actually not bad, but mind you, all these femoral patients in the United States now are being done with many of them with ultrasound and micropuncture. So I think we did learn a lot by using smaller needles and reducing the bleeding complications that also led to probably a mortality benefit. The next thing is actually chronic, kidney disease or contrast-induced nephropathy prevention strategies, which is simple with hydration. Dr. Brar from Kaiser in Los Angeles has shown a great study called Poseidon, and every patient got 3 ml per kilogram bolus IV hydration with normal saline, and looking at the left ventricular end diastolic pressure, their rate changed. If it is less than 13, they got 5 ml, and at more than 18, they got 1.5 ml per kilogram per hour. And post-procedure, the same rate was continued for 4 hours. With that, actually, LV-EDP guided hydration versus control, as you can see, we gave more volume, and definitely the event rate, which is the contrast-induced nephropathy, has been much better, 6.7% versus 16% with the LV-EDP guided hydration therapies. I think next, when we talk about in this position statement, talks about the importance of FFR. Here is a 5-year cumulative incidence of cardiac death or MI in FFR guided PCI is 10.7% versus in medical therapy it is 16%, and cardiac death is similar. All-cause mortality is similar, but primarily driven by myocardial infarctions. So I think this is FFR has been shown for the first time that it actually by FFR guided PCI, you can reduce the myocardial infarctions and not only urgent revascularizations as well in this paper. And imaging, we have heard both from Sanjog and also Gary that imaging is very important. There's one more slide in from me to support IVUS or OCT in terms of reducing MI, target lesion revascularization or stent thrombosis has been really great, along with cardiac death and TLR as well. So all these are important to make sure that the complete revascularization is can be achieved. Complete trial has been presented and showed that the first co-primary outcome, cardiovascular death or new myocardial infarctions, are much lower in complete revascularization than actually without culprit-only revascularization. So next, actually, I think is calcified lesions. What should be the approach in these type of lesions? SKY actually tells us very adamantly to use intravascular imaging in moderate to severe coronary calcium by fluoroscopy, and or if you cannot get a balloon that can be well expanded during lesion preparation. So stop right there, get a IVUS imaging going on or OCT, and look at it. If the imaging catheter before or after undersized balloon will not cross the calcified lesion, so that is an uncrossable lesion, you automatically go to either mechanical atherectomy or laser atherectomy. And if you get a good image that look at if the calcium is more than 180-degree arc of calcium, and if it is more than 5 millimeters in length and more than 0.5 millimeters in thickness, then also you should go to mechanical atherectomy, laser atherectomy, and nowadays we can use IVL, which is also currently approved in the United States. But if these high-risk features on intravascular imaging are not seen, then you can go with the full expansion 1-to-1 with a non-compliant or cutting or scoring balloon or an OPN balloon in India, and then go ahead with the stenting and image-guided optimization if you get a full expansion of the balloon. If not, still go back to mechanical atherectomy. How about recurrent in-stent restenosis? That's another place where we always have a problem, and we have Sky talks about it, but this is my own proposed algorithm for our patients with ISR. Look at the imaging, try to understand why there is in-stent restenosis. First of all, is it a neo-intima or a stent fractures? So by looking at that, if the patient prior to coming to you had a bare metal stent, you can treat with the drug-eluting stents or drug-coated balloons. In India, they are available, not in the United States. And if it is drug-eluting in-stent restenosis, we do have vascular brachytherapy versus actually drug-eluting stents. And if it is recurrent drug-eluting stent in-stent restenosis, then go for bypass surgery or vascular brachytherapy. We also want to make sure that we understand that LV unloading is very important in people with acute anterior wall myocardial infarctions, which are large and with EF less than 30%. We have Sky definitely says to wait for these results in the door to unload STEMI to see between age 21 to 80 with acute anterior STEMI involvement. And after obtaining informed consent, whether to go with immediate reperfusion, no LV unloading versus impeller for 30 minutes, and then unload the left ventricle for 30 minutes, and then open up the artery. So this is how we can actually do this trial, and we are one of the few centers in this country to doing this currently. So how about the bifurcation lesions? In the complex PCI subset, always we talk about bifurcations. They're about 20% of all our PCIs. And preferred approach in bifurcations is still provisional stent, side branch, provisional stenting. And but if it is a true bifurcation 1-1-1, and if the side branch has a lesion length of more than 10 millimeters, you can actually randomize them. I mean, you can actually probably think about two-stent strategy in them right away. And our preferred stent is a DK crush versus some other colleagues might do culotte or systemic T-stenting. But with the provisional stenting, you can see if if there's a good apposition and there's no lesion in the side branch, and less than 75% lesion in the side branch, no residual stenosis, no dissection, you can leave that artery alone. And people have done FFR, and if FFR is abnormal, maybe go ahead and balloon it and see and repeat the FFR. If it is still abnormal, maybe a T-stenting can be done. But all these complex bifurcations, whenever you involve, you have to do final kissing balloon, and a port has to be ultimately ended with a port, proximal optimization technique in these bifurcation lesions. How about the left main lesions? Professor Chen from Xiaoliang Chen from China has shown that DK crush is better than provisional stenting in people who had definitely complex 1-1-1 Medina lesions in these patients. So as you can see, the target lesion failure with provisional stent is much higher versus actually with the DK crush technique. How about the CTOs? I think just one slide. Sanjog Kalra has talked very eloquently on that, and the prevalence is 18 to 52%, depending on whom we read. There's a lot of conflicting data, and sorry for the typo, it is still class 2A recommendation for CTO PCI in people who have symptoms. But what we strongly recommend is do not do ad hoc PCI, and you need to train in all the techniques to get success rates of about 60 to 70%. And so that actually requires a lot of commitment from the operator. So what about DAPT in complex PCI? I think the current society guidelines are still going to be changed a little bit, but in people with a high bleeding risk, but still have complex multi-vessel stenting, it is preferable to go ahead and increase the duration of a DAPT at least for 12 months. So that's a class 2B recommendations, but I think in complex lesions, please do not shy away from doing dual antiplatelet therapy for up to 2 months. role of same-day discharge. I had actually even done atherectomies and sent the patients home the same day as long as they are very stable for the 4 hours after PCI. But SCI guidelines are stable angina with the negative biomarkers, no significant comorbidities, normal renal function and ejection fraction, successful uncomplicated procedures. So we do not say whether you used atherectomy or not. And they have appropriate home support and access to emergency care. I actually leave my cell phone number for them to call me if there's an emergency. So that's what actually it says. And one more thing about the role of balloon pumps is still not very clear based on the trials of BSIS-1. There is no data to support using balloon pumps in these patients. So protected PCI is something that we always talk about. We are trying to protect them against a hemodynamic compromise in people with these comorbidities and complex coronary artery disease and hemodynamic compromise. I think ideally coming to this, again, complex large bifurcations, multivessel disease, left main disease, EF less than 35, and people with heart failure, diabetes, please think about it and make sure you get the best outcomes on these patients. And so for saphenous vein graft, we also have talked about that as in the SCI statement as to which patient should be protected with a filter and who does not need to be protected. Either ostial or 2 distal lesions, probably you don't have to protect it. But if it is a degenerated graft with a lot of clot burden, it is better to protect it with a filter wire or distal protection devices. With that, I'll stop here and I'll be more than happy to take any questions. Thank you.
Thank you very much, Dr. Ramesh, for your superb lecture. It's excellent disposition of the subject, and the podium is open for discussion. I can see Dr. Rai. Any comments, Dr. Rai? Devabroto Rai.
Hi, Ramesh. Good evening.
Yes. Good evening, Dr.
Yeah,
Rai.
it's always a pleasure to listen to you. I have one query. Do you think there will be an expanding role for NOACs in addressing residual thrombotic risk in such complex situations?
Yes, I think the new statement will touch base on that in the SCI guidelines. But right now, we are recommending 2.5 milligrams of rivaroxaban has been the only one that has been studied. And so there will be a role for DOACs in the complex PCI subset, definitely.
Thank you.
Shirish, any comments, please? Dr. Shirish Hiramoth. Dr. Hiramoth, you can be seen. Make yourself unmuted. Any comments? Because Ramesh has given a very vivid account. He has touched all the facets of PCI, who are the very vulnerable population, how to use, how long DAPT, what sort of procedure should be done, bifurcation algorithm, CTO algorithm. So he has touched all the things practically. Excellent lecture, Ramesh. Very good lecture. Dipankar, any comments? Dipankar Mukherjee, Professor Dipankar Mukherjee. And Ramesh, 1,080 delegates and 27 faculties have watched your lecture and heard to it. And I think it was a very learning one. And thank you very much for, you had a lot of hardship today. You had a very complicated TAVR. And after all this work in the cath lab, you have joined us. So that's so nice of you. Dr. Rajesh Vijayvargi. Any comments?
Ramesh, very excellent presentation, and I think you have covered almost each and every aspect of intervention cardiology. Yes. I just want to inquire about your expertise about ambulatory and same-day discharge. So what's your assess site? Most of the time, is it transfemoral or transradial assess? And what percentage of the patient do have intravascular imaging for the optimized result where you are so comfortable to go ahead for the same day discharge?
Yes, a very good question, Dr. Rajesh. Great to see you. And unfortunately, you can't see me, but so our patients at my current center, I'm the one who don't use imaging a lot actually. And you know what, my percentage of imaging is 80%. The rest of my colleagues all actually use 100%. So we do a PCI, 100% of imaging, and the other people, I'm a little bit less than them. All our patients are radial, preferably, and about 98% radial. And we keep them for 4 hours and they go home the same day. But we don't actually demark them between atherectomy versus non-atherectomy, no. As long as there is no complication on angiography and imaging, we send them home the same day.
But Rajesh, you know, in our country, one point in the last point in the slide where he has shown to be discharged same day, Ramesh has nicely shown that there should be some backup mechanism. But I think in our country, we lack it very, very much. And I think it will not be very wise at this present status of treatment, where, you know, the patient leaves the hospital, goes 60 kilometers away, and there might not be any cath lab also. So I think at present, we should not think about that immediately. We can think it after a few years.
Man, can I have a comment?
Yes. Yes, Dr. Bahal.
Ramesh,
Bahal, please.
Ramesh, excellent and very educative. I have just one comment. Now, it is good to have so many, you know, guidelines and statements. We have ACC, we have ESC, we have Canadian Art, we have Bifurcation Club, CTO Club. So it becomes a little more confusing. Can you highlight like what SKY says differently, 3 or 4 points? Because everyone is giving now a position statement, a comment or a guideline.
Right. Dr. Bell, it's a fantastic point. The reason, the last time we have guidelines from ACC or SKY was 2011. And it's taking us 10 years to come back, and maybe this year we'll have guidelines come out. And for the past 3 years or 4 years, we've been going back and forth because new data is coming out. Every time we want to publish something, then the new trials are coming up. So then we were like, okay, we have to go back and let's talk about complete revascularization, adapt. And so one of the few things that they're trying to say is, number one, that do not ignore physiology and imaging in all these patients. We don't want to push or show a bias like same-day discharge, as Dr. Kahali said, that every patient should have a same-day discharge. Because even within the United States, some people live very close in metros. In the Chicago or New York is different than small places in West Virginia or North Carolina. So patients have to travel, and still there are helicopters here as well. So number one, I think we are not going to be pushing for same-day discharge as much as possible. We are not going to actually push for ambulatory PCI centers, number two. Number three, we do not have evidence for any cardiogenic shock therapies with support devices. So that's why they're called position statements, where we can make a position statement, but they will not come into guidelines. So guidelines are multi-center randomized, as you know, multi-center randomized controlled trials in different groups of population, and more than 1 or 2 large studies we need to have to make it into guidelines. So those are the things. Atherectomy will definitely stay. Imaging will definitely stay. Physiology will definitely stay. And left main probably, as some recommendation, it will come out because of Excel, but not very confident about it. And lastly, the cardiogenic shock, the support devices will be much lower on the recommendations.
Yeah. Can I just put one comment, Dr. Kali? A question.
Yeah.
Yes, Dr. Go.
Yeah,
please.
Good cover A to Z on all interventional work, Dr. Ramesh. Now, two things which are probably not talked means two things which I still feel are not clear. One is completeness of revascularization and outcomes. The complete trial relates largely to patients with acute MI. who have a culprit and acute MI patients. What is the status statement on those who are stable CAD? I think the data on complete versus incomplete, although we favor complete, if you could tell if there is something talked on in the position statement on that. And second is, with the improved antiplatelet therapy with ticagrelor type of agent, the status and the role of 2B3A inhibitors, which were probably more prevalent in the earlier years, maybe 5 years earlier or 10 years earlier. What is the status? If you could.
Right. So they did not touch specifically on these two things, but the 2B3A is now used about less than 5% in the United States. So that has gone away with as you mentioned about ticagrelor and prasugrel, very strong antiplatelet agents, and also probably small group of people are using cangrelor IV. And so 2B3A is gone off from the statement position statement. Number two, I think complete trial in the stable ischemic heart disease is a very complex one, especially with ischemia showing that there is no advantage over medical therapy. It is really going to be difficult to recommend complete revascularization in stable ischemic heart disease. So I think that's where we will see we cannot make any recommendations on that particular point as well.
Okay.
Nice. And Ramesh, 1,100
yes,
delegates are watching this program. So thank you very much, Dr. Ramesh. I think Subhash will be getting delayed. And I would request you to be with us. I know that you have a very hard day today over there, tackling with a difficult travel case. But still, I would request if you can be with us for next few minutes. And I would request Dr. Subhash Banerjee to talk on another very important aspect of chip lesions, managing hemodynamic collapse in chip cases. So Dr. Subhash Banerjee from Dallas. He is the Director Interventional Cardiology in Dallas Heart Institute, and also he is in different chairs in American Heart Association, in SCAI. He is author in many books. I remember he has written a chapter in Brownwell's Book of Companion along with Emmanuel Brilakis on SVG, stenting, and he has got several contributions in several hundred papers and books, chapters in books, different books to his credit. And he's a great academician, a great cardiologist. So Subhash, please.
Thank you all. Thank you for the invitation. I'm actually sitting in my cath lab, so I may have some audio disturbances, so I apologize for that. And I really appreciate the kind invite to talk about managing hemodynamic collapse during chip cases. So my disclosures are, and first and foremost, is that I'm going to talk on the basis of cases that I've assembled from my own experience, because this is a talk you can give by borrowing slides or quoting studies. And I will be making some points which are factoids, because the time would not permit me to explain each of these cases in extreme detail, but I'll be available for questions. And here are my disclosures. None of my positions and statements reflect the official position of any of these organizations that I am affiliated with. With that disclosure, let me start off with my first case. And I think each case will have hopefully a learning factoid that I want to share, and something that from my own very recent experience. This is a story of a patient who presented with stable ischemic heart disease, severely depressed LV systolic function, and multiple wall motion abnormalities. I won't describe each angiogram in great detail, but you can definitely see the diffusely diseased left main and calcified LAD, and especially the left circumflex, the RCA is small caliber. Here is his LV systolic function. As you can see, there are multiple areas of wall motion abnormality in this patient, and the overall LV systolic function is estimated in the range of 30 to 35%. We briefly wanted to initially take a femoral approach because you want to perform this case with mechanical circulatory support. On the left panel, you see the very calcified distal aorta, very severely diseased common and external iliac artery. You see on the right side, on the left side, very severe calcifications and calcified nodules on the common femoral artery. And on the right side, a pre-existing multiple stents in the common and iliac, and then there is a patch of endoarterial repair. And the third vessel here, the most medial one, is a graft, which is a fem popliteal graft, which comes very far, very distal, just besides the stent that is in the external iliac artery. So this posed a very significant challenge how to deal with this patient. What we initially did is try to get right-sided common femoral access just through the patch. We tried multiple attempts, and I'm giving an abbreviated view. The wire actually went besides the stent and between the wall of the stent and between the arterial wall multiple times, but we were able to successfully canalize. Because there was a pre-existing stent, we wanted to use the left common femoral artery as the initial approach. We treated it with intravascular lithotripsy to break the calcium. And after breaking the calcium, as you can see, there are still lots of areas of calcified nodules present. So we decided to put a covered Viabond stent, and on the left panel is the deployment of the Viabond stent. And after post-dilation, we had a good area of caliber vessel that was restored. And then we obtained acute vascular access using 2 Perclos through the Viabond stent acutely. And this strategy works very well, and it is extremely safe. And after getting access through the Viabond stent, we deployed 2 Percloses to pre-close the Viabond stent and deploy our sheath through that. And here is the pictures of the advancement of the sheath of the impella and the dilators, and the sheath was placed. And a single access, so what we do is we place the CP sheath of the impella, and through which we deploy the 2.5 impella, and there is still remaining space for a 7 French sheath, which is deployed for delivering the guide catheter. So single access obtained in this patient. And the PCI, briefly, the PCI was performed with mechanical circulatory support with atherectomy and rotablation of the left circumflex and the left main, after which bifurcation PCI was performed of the circumflex system. After adequate predilation, you can see the heavy calcification. We use extensively OCT imaging to guide our strategies. I'm giving you an abbreviated view of this case, and after which bifurcation stent strategy, the left main of the artery of the system was also treated after adequate predilation and imaging. And at this time, the patient started getting a little hypotensive, had to be started on a low dose of dopamine. And after left main stenting, the patient suddenly lost a significant amount of blood pressure. His blood pressure were in 30s. And we were about to start CPR on this patient, but his EKG remained tachycardic but stable. There was no ST elevation, and the angiogram showed that the coronary system was fairly well perfused, and the motion of the heart was little limited. And here is the angiogram we took of the peripheral system. I would like you to play it and make a very important point that when you have a sudden pelvic arterial rupture and perforation, the extravasation of contrast can be very subtle. And this happens unlike coronary perforations where there is extensive staining. Pelvic perforations can be very, very subtle because the intrapelvic cavity has very low pressure and the arterial system is very high pressure. So even a small amount of puff that you can see where the arrow is can lead to sudden profound hypotension and hemodynamic collapse. So the vascular perforation was the cause in this patient. We quickly treated this patient with a covered stent. And here is the deployment of the Viabond through the contralateral artery after the sheath was removed. The 7 French sheath was removed from the coronary, and a Viabond stent was placed. And after adequate post-dilation, the final picture is shown onto your right panel. Let me play it for you for a second. And here is the final picture with no perforation. The patient recovered, and therefore looking out for subtle vascular perforation and complication can be extremely useful and save a patient's life. The second case is a case where we used mechanical circulatory support in a patient with stable ischemic heart disease who was deferred from coronary bypass surgery because of comorbid condition, and especially because of a recent need of a biopsy of a heavily calcified lung nodule, which later turned out to have stage 2A lung cancer. And as you can see, the first picture shows the baseline with heavily calcified LAD, distal left main. And the second picture shows after we have just completed, after OCT guided imaging of the mid-LAD, the left main, after CSI orbital atherectomy. At this time, we saw that there was a distal lesion, and as you can see in the initial picture also, and the picture that is after the initial completion of the case, that we felt that we also wanted to treat the lesion distal to the existing stent. Now, whether it was a right or wrong decision, time will tell, but we then recrossed the artery and tried to perform balloon angioplasty and stent placement. For this region, we used 2.75 millimeter non-compliant balloon and then placement of a stent. And this is the result after placement of the initial stent and post-dilation with a 3O balloon, which could have been oversized. This is a very rampant, large perforation of the coronary artery, but the story didn't finish here. We quickly used balloon tamponade followed by delivery of a low caliber, low profile papyrus stent, which is the new covered stent, unlike the other stent. And then the papyrus stent was placed here. A 2.75 millimeter papyrus stent was placed within this artery and post dilated with a 3O balloon. The patient stabilized. And this is the picture after the first papyrus stent was placed. As you can see, there is a very distal narrowing and an acute step down. We felt that there could be either, because the patient was on high dose of pressors, we also felt there could be an element of vasospasm. So we gently wanted to dilate the distal edge of the stent to improve distal flow. And apparently we used a 2.5 millimeter compliant balloon to do the distal dilation. And this was the result after the distal dilation after the first papyrus stent was placed. Now there is a perforation in a different area of the vessel along the same projection, and the patient required a short duration of CPR. After placement of a second papyrus stent overlapping 2.5 millimeter with the initial stent, the patient was stabilized. And this is the final picture. As you can see on the right panel, emergent placement of a pericardial drain, and the impella was already there. So the patient remained relatively stable and was able to be recovered with the placement of a pericardial drain. The patient, it took about 4.5 days and a total of 6 days of hospitalization for the patient to recover fully from it. And before relieving before removing the impella and the pericardial drain, we also recanalized the patient's total occlusion of the right coronary artery. Getting back to why this perforation happened, first of all, we can question the judgment of going after the distal lesion. We could have left it alone. However, the teaching point was that when we reviewed the OCT, we found this very eccentric location of this calcification, which is not greater than 270 degrees, but it is very localized and very eccentric. And it has been very clearly shown, contrast to IVUS, that the presence and knowledge about the thickness of the calcified nodule in the coronary artery leads to, in the setting of overinflation, leads to inflation and overstretching of the non-calcified parts of the vasculature and could lead to coronary perforation. And therefore, I believe that that is the possible mechanism that underlay this large area of perforation in this particular patient. Here is the picture of the fully recanalized artery. As you can see, the impella and the pericardial drain is still placed, and after successfully recanalizing the right coronary artery and complete revascularization in this patient with with low EF and multivessel disease, that the pericardial drain and the impella was successfully removed, and the patient was discharged on the 8th day of hospitalization. So I think this is a good case to know about how to interpret OCT imaging and what are the strengths of OCT imaging and how eccentric calcified nodule can lead to severe perforations, especially in medium to small caliber coronary vessels. Third case, this is a case of, I did a cadaver on a patient with bicuspid aortic valve. He's 53 years old. After a few days, we noticed that he is developing ischemic EKG changes, and the TAVR valve has descended down and caused acute obstruction of his coronary arteries, and we had to embark on bilateral radial access to snare and replace the core valve, the evolute valve, and actually raise it up so that the broad part of the valve does not fall in front of the coronaries, and the waist can remain at the level of the coronaries to provide adequate perfusion. As you can see, I suggest that when you have to do that, you should use the right radial axis to grab this side and the left radial axis to grab the contralateral side, so you can get better tension to snare these valves. This can also be the case when you have low placement of the TAVR valve and inability to cannulate the left main coronary artery. And I think this was the challenge we were facing. So let me go through this case. This is a very instructive case. And after multiple attempts, we were able to displace the valve. We wanted to make a more controlled displacement, but as you can see in this patient, the valve actually moved uncontrollably. And of course, it actually ascended into the ascending aorta. And the patient ended up in acute shock from acute AI and also from limited perfusion to his coronary arteries. The patient has a two-vessel disease and a proximal LAD disease with bifurcation, not shown here, of course. The message of the case is shown here, that after replacing the valve and moving the valve up into the ascending aorta, we quickly, you can see their heart is complete standstill. We are trying to place a second valve. We are deploying a second valve through the initial valve. And we placed a second overlapping valve to close off and treat the acute aortic insufficiency and also provide perfusion, because this valve was now deployed correctly. And the waist of the TAVR valve is sitting right opposite the coronary calcification, and that provided enough coronary perfusion. The patient regained spontaneous heart contractions, but still was in acute shock. And through this, through these two valves, we then brought in an impella catheter and presented and provided perfusion because intra-aortic balloon pumping was not sufficient. But despite providing the impella support, as you can see, the motion of the heart is nearly non-existent. And when we performed echo on this patient, as you can see, you will notice that the LV here, this is the LV with the impella in, it is completely not expanding with volume. And the RV after prolonged CPR is completely dilated. Very well dilated RV with no volume in the left-sided and the impella catheter placed. And that is why we believe that the left-sided impella was not providing any output. And because of that, we placed the RP impella catheter in this case. As you can see, the right-sided impella catheter is going in and into this case. And here it is shown. The right-sided impella is placed from a vein, a venous axis. It is coming up, and here is the right-sided impella. And so this patient has both-sided impella support, the left impella support and the right impella support. Fortunately, the left ventricle and the right ventricle started recovering. You can see now the left ventricle is feeling much better, and the right ventricle dilation is much less compared to before. The patient, believe me or not, did extremely well and was discharged successfully home, and it still follows up with me as an outpatient. And I think acute recognition of the hemodynamic conditions and with imaging and with proficiency to place both left and right-sided impella were crucial to saving this patient's life. And I think this was another interesting case of hemodynamic collapse. I want to share this case in patients who have got severe vascular disease and require large caliber access. We sometimes use, and they have distal aortic occlusion that preclude recanalization and peripheral intervention. I sometimes use axillary artery access. And I want to show this angio because my technique of doing axillary access is very slightly different from what surgeons do. The subclavian and axillary artery can be divided into 3 parts. And this is the second portion. This is the first portion, and after the subscapular artery, you can see here, this is the third portion. And unlike surgeons, I like to get access into the third portion of the axillary artery, although this segment is close to the brachial nervous plexus. But I use ultrasound to locate the positions of the nerves surrounding the artery, and I place the needle just between those. The real reason to do so is because this part of the axillary artery is compressible against the humeral bone, and this is an important trick. Surgeons who can open up the area and do a cut down can do it here, but as a percutaneous specialist, and I use perclose to close these arteries, I always do it here. And this is a very simple PCI in a relatively short segment CTO. And the first picture shows the CTO with axillary access and impella placement. And the second one is the picture of the successful recanalization of the short segment CTO. The patient required extensive stenting because of atherectomy. But after the case was over, the patient became acutely symptomatic and hypotensive. And I want to share with you how does axillary artery perforations look like. Again, the axillary cavity is a low pressure area, and as you can see, the signs of perforation can be very subtle. It can be treated very effectively with balloon tamponade. And in this particular case, groin access with a very small French catheter was used to place this balloon and tamponade the artery. So in the lesson is that 2 lessons, that the third segment of the axillary artery is where percutaneous specialists should gain axillary artery access, and a bailout small caliber access should be present in another area, either the right side brachial or right side radial or in the leg, to place a small caliber 5 French or 6 French balloon, peripheral balloon, to occlude the artery in the need of axillary artery perforation, which can be extremely difficult to manage otherwise. And this is the final image. As you can see, the perforation has been adequately treated. There is no leak, and the patient recovered extremely well. And this was the potential site of calculation, perforation. Deman, I have some more time. I don't want to take someone's position, but I have a few more interesting cases to share if time permitting.
Okay, Dr. Rai, can we proceed for next 10 minutes? Because really I was seeing so much, glued to the slides of Dr. Subhash Banerjee, and I think you can continue for another 10 minutes.
I will take less than that. This is a case of, I want you to look at this case. The first case is a baseline angio of a patient who is going to have impella guided support. And the difference between the first picture and the second picture is that the SFA, the profunda artery, is here, the SFA is here, and as you can see, after placement of the impella, there is no flow, neither in any of the vessels. So what I want to show is that when you have a large limb, like the iliac or the common femoral or the profunda or SFA, completely occluded by a large caliber sheath, you can cause acute ischemia of the leg, you can cause compartment syndrome, and the amount of lactic acid generated from large body of muscles can be so profound that it can cause severe vasodilation and hypotension. I've experienced it few times in my life, and this is one of my recent cases. And what I suggest how to overcome this problem is to foresee it. This is a patient who has left-sided antegrade access into the SFA going downwards. You take the 6 French sheath and connect the side port of the sheath to the common femoral artery or another artery of the body on the side port. So it perfuses the antegrade limb and does not cause the compartment syndrome. So unlike perforation, compartment syndrome can also release a lot of acidosis and lactic acid and cause acute profound hypotension to cause hemodynamic collapse when coronaries are looking good. And this type of antegrade access and using the side port to connect to a contralateral sheath can be very useful to provide bypass circulation to the leg when the sheath is occlusive in the iliac and common femoral arteries. So another tip to use when you are doing large bore access. This is a very recent case, Diman. I think you will like this because I think you presented a case like this. This is a patient, very briefly, came with a delayed non-reperfused inferior STEMI. And this was the angio of his case. I'm giving you only a few pictures in the interest of time. This is the left coronary system. You can see the acute cutoff of the circumflex, and this is the LAD. I'll let you see it. There is no or barely little bit of filling, a few spicules of contrast in the distal right, but not much filling of the distal right. Here is the picture of the right coronary artery. And we decided to proceed with intervention of the right because of the size of it and the inferior ST segment elevation, although this seemed like a dual culprit. And I'm cutting through the sequence of the case, but this is going to be a very interesting case. And after multiple ballooning and IVUS to confirm distal position, we could not restore flow. And as you can see, this is faint amount of flow, looks like also distal amount of residual thrombus, and maybe some dissection of the area of the artery from profound and multiple balloon inflations. But I think at this time, the patient became acutely hypotensive and extremely hypoxic, extremely sudden acute hypoxia and hemodynamic collapse. And I want to present some options for our audience, and hopefully there are some fellows and residents. Options A, proceed and complete the culprit RCA PCI. B is do echo. 3 is immediate referral for cabbage. 4th is mechanical circulatory support. E is diuretics and diuresis. F is mechanical circulatory support and multivessel PCI of RCA and left heart and left circumflex. And G is right heart catheterization. And I don't want to belabor the point, but what we did, while I give you a few minutes to think, we initially proceeded with very quickly placing a swan and doing a quick shunt run and confirming with transthoracic echocardiogram. In the interest of time, I want to show these tracings. On the left is the RA panel, low RA pressures, RV pressure, 50/18. PA pressure is high, 50/24. And the wedge pressure with V waves of 55, and the LVEDP and the representation of the mean wedge pressure is actually low and not as high as we expected. So any thoughts about the diagnosis? This is the case from November 10th, and I would never forget this case because this was very, very interesting. Systolic blood pressure came up slightly after a brief amount of CPR and oxygenation. However, the diagnosis of the case was revealed very quickly by our fellow who did a transthoracic echocardiogram and a shunt run, which revealed that the PA saturation was very high. As you can see, it was 85% in the PA compared to 94% in the aorta. And I don't want to belabor the point, but the QPQS ratio was about 4. And at this position, at this time, we did not proceed with the PCI and immediately performed a transthoracic echocardiogram because you can see on the right panel, on the left panel, the contrast and that is escaping from the LV into the RV very, very quickly and also pacifying the gap in the septum. We also called our TE expert, and because the patient was now intubated, to proceed with TEE. As you can see, the large serpiginous complex septal defect in the inferior septum, and the patient has a large VSD most likely because of a delayed reperfusion and unsuccessful PCI and multiple other causes in this particular patient. And these kinds of VSDs, I know in India, they have more experience than us in the US, can be very difficult. This is some additional pictures that the patient of the case, there is no significant MR, there was no significant AI, and the large rent of the VSD in the inferior septum is visible here. And this was a very complex VSD. We calculated the gradient across this, and the flow was very, very large, confirmed with our QPQS ratio. And the color flow through the VSD is also very, very clear in this patient. This is a very complex situation, and the decision what to do in this situation can be very challenging. There is literature for deferred surgical treatment, but I think that selects or pre-selects patients who have acutely survived the insult. I do think that mechanical circulatory support is useful, except for ECMO, which has a tendency of significantly increasing the afterload, and I think is contraindicated unless it is combined with Impella or balloon pump to reduce the afterload in this patient. So an Impella may be an option. Also, endotracheal intubation and PCA2, PCO2 maintained slightly at a higher level is improvement, is also better because it also drops the afterload and reduces the shunt flow. We did try to cross this VSD acutely, but I was unsuccessful, though I crossed it from multiple sides. You can see this is the arterial side crossing. We were able to thread the catheter, but because of this serpiginous and very complex tract in the acute setting, we were very, very unable to deliver the Amplatzer closure device, and the guide wire and the catheter would fall off at multiple times. The patient did very well with mechanical circulatory support with Impella. And then underwent surgical repair successfully on the 7th day and was thankfully alive. But I think acute detection of this case and recognizing and sometimes doing nothing and recognizing the hemodynamic consequence of what's going on and taking the time to do this assessment can be life-saving, and this case portrays that. So to conclude, I know there are lot of different kinds of examples that can be done. And I know I'm speaking to a very experienced group of investigators and interventionalists in India and around the world. And I also know that your training programs are extremely strong. So my motto of dealing with hemodynamic collapse during CHIP cases is to anticipate and not react. If you think about the background clinical conditions and you are thinking constantly what could happen rather than trying to find what I should do, I think it will always lead you ahead of the game. I think I categorize acute collapse, not complication, but collapse during CHIP cases into 4 major categories: coronary perforation, major abrupt vessel closure or no reflow, which can be from multiple different, I showed you some examples, but contrast, air embolism, Raj dissections, distal embolization of a large major vessel, loss of circumflex or major branch, vascular access complications like compartment syndrome or perforation, structural integrity of the heart is destroyed like VSDs, or acute valvular dysfunctions like acute MI and papillary muscle dysfunctions, and of course arrhythmia like VT, VF, and are 4 large categories that one should think of. But I can tell you my message is that the best way to deal with hemodynamic collapse during CHIP cases is to pay close attention to the profile of the patient and to the conditions and diagnoses that lead the patient to the table. And I think that way we can understand and anticipate what potentially could go wrong. And each of these 6 cases that I've shared with you have a telltale sign that predispose the patient to a certain type of complication. And I hope this small piece of examples from my own experience would be illustrative, and I would be open to comment. I also am grateful for the moderators and leaders in India to provide me with the additional time. I hope it was not a waste for you. Thank you again for providing the platform. I'm delighted to be a part of your forums. Thank you.
Thank you very much, Subhash, for your superb lecture, fantastic exposition of the subject and fantastic cases. So there is a very, valuable faculties over here, a very learned faculty. So comments from you, Dr. P.K. Gwell, Dr. Sanjay Taggi and Shirish, all are very senior operators, very highly experienced interventional cardiologists. And really, Subhash, you have shown some spectacular cases and how you made the patient survive out of this catastrophe. You have given a very nice illustrative experience of what can be the complications of CHIP PCI. And I was just remembering the lines from Columbus' book, The Tips and Tricks in High-Risk PCI. He has written 1, 2, 3, and you have shown exactly sudden vessel closure, and he has given the tips how to prevent it also. So you have done a teacher's job, master of master. Anyhow, so Shirish, Sanjay, please quick comments.
Just to compliment Subhash Banerjee for showing such great cases, which are very educative. I think everybody would benefit from that. See, VSD during acute MI have been experienced, but problem of putting in implanter devices that even sometimes the wire can cut through and enlarge the VSD. That can further compromise. So you did a right job by unloading the heart and then taking up the patient after healing up and taking up for surgery. That should go for as a message to everybody.
Yeah.
Thank you very much.
I appreciate the
problem, you know,
sometimes restraint is a good news. So I think it is also an important attribute for interventionalists.
Yeah, but the problem in our country, you know, Subhash, that impella is so exorbitant that we can't think of it. So what should be the impella in our country? IABP doesn't provide the same sort of advantage as impella gives, you know. Very few patients in our country, not to tell of 2 impellas, even 1 LV impella.
So I think tandem is maybe slightly cheaper, but what we really need to do, I don't know why that's why I put the disclosure before. I think we have to develop a localized indigenous impella system, which is cost effective for India. And I think the collaboration of us and the CSI and CI, I think we can definitely create this with industry. And I think we definitely need to do this. We need to break through this barrier of cost and provide low cost options for our people in India. And I will be fully supportive of this of any way I can.
Thank you very much. Thank you. Thank you, Subhash. Thank you. Shirish, any comments? Shirish?
I think it was an outstanding talk. I mean, I enjoyed every line of it. And having done so much work, then to find a ventricular septal rupture at the end, it must be so disturbing. Yet to hold your nerve, try to correct, I think it shows features of a great operator, great mind. Thank you indeed.
Thank you very much. I'm humbled by the comments you guys make. I am very familiar with the high quality work you all do. And every live case, I am awed by the cases you all do in all over the country. So I'm really privileged to be amongst you all, and I will extend my wholehearted support in any way possible. And I've said this to Diman, and I want to say this to you all. Again, thank you for the invite. I hope it was illustrative.
Thank you very, very much again, Subhash, for your excellent case demonstration, excellent lecture, magnificent, outstanding, I should tell. And I hope that in the next meeting also you'll be with us. Please keep second week of June. Probably our annual meeting will be virtual one. It will not be possible to see in person, but you know, please join us second week of June, and Saturday, Sunday. It will be Saturday, Sunday to all the faculties as well. We haven't fixed the date as yet, but we are going to fix it within a short time. So thank you very much for your outstanding lecture. It's very educative. Ramesh, any comments? Ramesh Dagubati? Ramesh, are you there? Dr. Dipankar Mukherjee? So anyhow, just I want to tell that on behalf of CSI NIC, we are very grateful for your excellent lecture, and you are very busy in the cath lab. You told that you had a very critical TAVR case. Ramesh also had, and despite your hard work, you gave time to us, and within a short notice, you have done it. Both of you have done it. So thank you very, very much on behalf of CSI NIC, and it's our great pleasure. And please give a big hands to Dr. Subhash Banerjee, Dr. Ramesh Dagubati, Dr. Gary Min, and Dr. Sanjog Kalra. And I also extend my personal gratitude and gratefulness to all the faculties present over here, giving so much of time and making it a wonderful meeting. And we hope that in future also we'll be doing such endeavors. And thank you very much, our guest faculties, our faculties from abroad who are Indians. You are making us proud, really proud to see such patients. We are proud of seeing such cases and how you are saving the lives in precarious condition with outstanding vision and modality of treatment. Thank you very, very much. And I close the session, and I thanks everybody, Dr. Devabrata Rai, Dr. M.K. Dash, and I would invite a short comment from Sanjay Tagi and Shirish and Rajesh before closing the chapter. Just very short comments. Sanjay, any comments?
No comment that you have organized such a great interactive conference in such a difficult time, and the lectures were outstanding. It have been very educative. So compliments to Professor Dhiman Kahali also, and Dr. Devabrata also for organizing such a beautiful CSI initiative.
Incidentally, Subhash, Sanjay was also the Director General of our medical services, All India. A great post, you know, we all respect him. And he is also the Professor Director of, you know, of a postgraduate medical college. So in Delhi. So thank you very much, Sanjay, for your time, and we'll be meeting soon. Rajesh is also a professor in IPGMR. Any comments, Rajesh?
Sir, very nicely conducted program, very informative and educative. Excellent cases by Subhas. So it's admiring how do you go ahead with bypass graft via the femoral and the axillary approach. That's fantastic and great learning with this session. I think it should continue on with this what's a COVID pandemic we are facing about. Thank you each and everyone from the organizing committee and also the various faculty members. Thank you very much,
Rajesh. And so we'll be, with professor's permission, we'll be bothering Subhash in future also. Subhash, be ready for that. And maybe in short notice.
Thank you. This is
So
outstanding
thank you very
effort.
much. And I give my heartfelt gratitude and thanks to each and everybody, including our foreign faculties and our national faculties. And also I give thanks to the delegates. 1100 delegates were there. Today there was a live transmission, Subhash, from German Heart Center on IVL and how to deal with the calcified lesion. One long program, and tomorrow also they have it. It starts Indian time 4:30. So I also a regular attendant of that CSI, but that is not CSI India. And thank you very much, all the delegates. And I also thank Mr. Raghu and all his members for giving us an excellent tech support for the last 4 hours. Thank you very, very much. It's real pleasure to see all of you and gathering so much of knowledge, so much of information. Good night. Jai Hind. Good night.
Thank you.